This conference will now be recorded.
Hello everyone. A very good morning, good afternoon and good evening to everyone who is present here for today's webinar. Before proceeding further, first let me introduce myself. I am Maket, pleased to welcome you to this conference. Firstly, I would like to thank the researchers from their respective field of research for taking their precious time out and making to this event. It will be my pleasure to introduce to all you all to the speakers who are here today to share their knowledge. Before we begin with today's sessions, please allow me to deliver a brief introduction about our organization and further instructions to proceed. Scisynopsis conferences provides the opportunity to discuss latest cutting-edge clinical and basic scientific research from all the elements and fields of life sciences, medical, clinical, chemistry, technology, medicine, pharma, management, engineering, and technology. Gain the experts' opinions on current research and issues across the breadth of science and engineering. We remain curious and passionate towards providing a forum for scientists, distinguished researchers from universities, research institutes, companies, laboratories with the latest knowledge on intriguing topics with wide range of great events to get the knowledge that can reshape the today's world. Thank you once again to all our attendees of today's conference and hope you will gain knowledge from the sessions. Now, as some of our attendees are new to GoToMeetings app, so I will explain you the important settings and procedure how to begin with that. As you have joined through the link provided, you can see the screen where you can find four icons at the bottom center of screen. Mic. Click on that to mute or unmute yourself. So I request you all to stay muted while our speakers are presenting their research work so that it doesn't cause any disturbance to them. Camera. You can use this button to share or unshare the webcam. If you have the option to share the webcam, you can do it or else it's completely your choice. Screen. You can use this button to share your screen. During your schedule, when I'll call your name from my side, I'll be making you the presenter. When I'll give you the access to share your screen, then you need to click on this button and you will find a pop-up window which you should accept to share the screen and you can proceed further. For MacBook or Apple device users, once I make the presenter, then you need to give permission to share the screen in your system preferences. After that, you need to log out from the session and need to join again from the same link and share the screen for presentation. Leave. This is your last icon. Clicking on this button, you will leave from the session. On the top right corner, you can find three icons, people, which shows you all the attendees of the webinar. Chat. In this option, you can chat with any other participants and with me for any queries. Settings. You can use this button to check for the settings for your speaker and microphone. So as mentioned, kindly remain muted during the presentation so that the presenters don't get disturbed, and for any questions you can ask me or write in the message box too. Finally, I would like to request you all to give a brief introduction about yourself before starting with session so that we can know about you virtually. Now, let's move into our sessions. I'd like to invite the first presenter, keynote presentation by Zhenghuan Liu, Guangzhou University of Chinese Medicine, China. Title of the presentation is Neuroimaging by Evaluation, Now Renovate and Neuroplasticity of Acupuncture in Children with Cerebral Palsy. Dr. Jen, are you ready with your presentation? Dr. Jen, Dr. Jen, are you able to hear me?
Yeah. Can you see me?
I can't see you, but I can hear you.
Can you see me? Can you hear me, speaker?
Yeah, I can hear you. Now I'm
Ah,
going to make you the presenter. Please click on the
oh,
button.
ah, okay. Okay. Uh, Conference chairman, good evening, good afternoon in China. Do you, can you see my PPT? Conference chairman, do you see my PPT?
No, we don't see it.
Okay, thank you.
Yes, now I can see your screen.
Yeah. Mm.
Can you please share your screen? The
Yeah,
one with your
okay,
PPT?
thank you. PPT, yeah. Mhm. I different tubular. Can you send me? Can you send my PPT? 还有 Good evening, Good afternoon. Can you see me? Can you see my PPT?
No, we cannot see it.
那个待会儿过来看看怎么分享一下这个 PPT 啊？这个怎么去分享？把我的 PPT 分享一下。窗口，我找不到我的 PPT。
是要拖进来。
这不是共享这里。这是什么？把这个去掉。
对。
这个共享在哪里？这个找不见我这个。
是在浏览器吗？对，哦，我知道了。
这个不要这个。
PPT 是在这个。
不是，我这个 PPT 已经打开了。
那现在已经分享了。
啊？
现在已经分享了。
这个传不到他会议上。
它是分享整个屏幕的。
啊？
它是已经在分享整个屏幕。
不是。哎，这个有了。哎，我取消了我的怎么都共享。
他那边还要审核。这个是由他那边控制的。
啊？
是由他那边控制的。
就这个。
因为我们退出来之后。
这个就找不到啊。没办法共享屏幕。最后还是拿你那个最好，两个它放一放。
是要让对方让他们，你看哦，要让主诊者就是他们，这里他们没开通，我们就不能点。
他不同意我做这个。
Dr. Jen, Dr. Jen, are you able to hear me?
This conference will now be recorded.
Dr. Jen, can you share your PPT with Veronica? We'll play it instead of you.
Here, the treatment method and the international progress include visitor, originator, register, drug, and most maybe hamster. 应该可以啊。And then social. The third method of effective. Why? People with cerebral palsy and MI, skull MI, and usually and PVL and encephalomalacia, Paduria deformity, brain atrophy, and torch infection, derailment, and topia, and man dysplasia, social.
Dr. Jen, can you please share your PPT? We can't understand your presentation.
Thank you, Dr. Shrikant, for the production presentation. Does anyone have any queries?
Yeah, radio
Can you can you
PPT.
please email or
Yeah,
send message it
I know. I radio PPT.
yeah, can you
No,
please send it to Veronica?
speaker PPT. Cerebral palsy with children. Neuro imaging. You see? You see PPT? I can you hear me, speaker?
Chinese medicine family
Can you hear me, speaker? Dear
Yeah,
chairman, dear chairman, can you hear me, speaker? Sorry, sorry. I'm sorry. I heard
Dr.
in
Jen, no problem. You can
podcast.
share your PPT to Veronica. I can play on behalf of you. Can you please share it with Veronica?
Dr. Raymond? Dr. Raymond, are you ready with the presentation?
Teaching Chinese massage together.
Dr. Raymond.
Cerebral palsy with
Dr.
children.
Raymond, are you ready with
Very
the
nice.
presentation?
Acupuncture treatment is important medical therapy. Teaching team. Our team, 120 people, have 100 beds in the children's rehabilitation, our hospital. Our team include children neurology, psychological therapy, speech education, music therapy, physical therapy, nursery, acupuncture therapy, and traditional Chinese medicine together a team. Rehabilitation center in our hospital include 6 departments: tradition medicine department, acupuncture, and massage. 100 children with cerebral palsy were selected. 132 boys and 68 girls, 80 of 2 to 7.
Dr. Raymond, can you please unmute yourself? Okay, now I think Dr. Raymond is not responding.
Okay, now let's move on to the next presentation by Molly Towns O'Brien, Australian National University, Australia. Title of presentation is Brain Injury and Prison, Overrepresentation, Prevention and Reform. Dr. Molly, are you ready with your presentation? Dr. Molly, are you
Hello,
ready?
can you see
Hi,
me? Hello.
uh,
Um,
I can hear you.
okay, and I'm trying to set my turn my camera on, and I
Okay.
think I've got it. Yes,
Yes,
I have
I
it.
can see you.
Now,
Now I'm
I'm
going
going,
to make you the presenter. Can you please click on that
okay.
button?
Yes, I will. You mean the share button?
Yes, I have shared you. Please click on that button.
Open systems preferences. What button do you want me to click on?
Yes, you might have got.
Oh, select the content I want to share. I want to share this. Um,
Are you using a MacBook or Apple device?
I'm using a Mac and I
Yes.
now have shared my screen. Can you see it? Can you see my screen?
No. Can you,
No.
for MacBook,
All
you
right,
need to
I will
go.
try again. I will try again.
Yes.
It says
For MacBook,
select the
you need.
content you want to share. Well,
Yes.
I want to share my PowerPoint and share screen. Okay. And now it says share the content you want. So if I play my PowerPoint, it should show up here, shouldn't it?
Yes.
Okay. Screen sharing requires permission to capture my
Yes.
screen. So what do I do to give it permission? I
To
open
share the
system
screen in your
preferences.
system preferences. Let me read out to
Okay.
you once. For Apple device users, once I make the presenters, then you need to give permission to share the screen in your system preferences. After that, you need to log out from the session and need to join again for the from the same link and share the screen for presentation.
So I need to log out from this meeting. Is that what you're
Yes,
saying?
yes.
Okay.
And need to
So
join
I
again
have,
from the same link.
okay, I need to leave now and then I need to go to my computer preferences and select share.
Yes, first you need to go to permissions to share the screen in your system preferences. After that, you need to log out from the session. After that,
Okay, now where do I go to select the preference to share? Hey, Charlie, help me. Ah!
Okay.
They are seeing me and I can't seem to make them see. I have to go to my system preferences
Maybe that's the gearbox. That's right.
right there. And what do I choose?
you need to
What do
give
I
permission.
choose?
You need to give permission to share your screen.
And in Mac, what would that be called?
It's right there. It's right there.
Okay, I'm trying. I have to log out.
I don't think so.
I do.
Machine scan requires permission to capture your screen. Please open the system to grant permission. Okay, you're right.
Okay, now where do I see it?
Screen sharing, security, privacy, screen sharing, recording. Maybe there. Screen recording.
Do you know what it's called in my system preferences?
It's to share the screen. It's the permission to share the screen.
Yeah, I know, but you look at the screen. So I should look at the screen, I guess, right? Where's the screen?
Displays.
Displays, right? You mean displays? Display settings.
Yes.
Is it display settings?
Yes.
I don't see anything about permissions here.
I'm having a.
So we're in settings. Where in settings do you change the permission of the screen?
I'm in my system's
Security,
preferences.
maybe security and privacy? Oh, screen time extension.
Hello, Dr. Molly. Are you there?
Yeah, we're clicking on
Uh,
go to.
please, yes, please follow my guidance. Please open
We're
your
almost
setting.
we're getting there. We're getting there. It'll just take a while. We found
Okay.
what we need. We have to unlock it, and then we have to give go to permission.
Yeah. You have to give the go-to permissions in the settings, and you have to leave the GoToMeetings app and rejoin again. Mm.
Hello, everyone.
Yes, Dr. Molly. I can see you. Can you
Oh,
share your
good.
PPT?
Will I press share? Ask
Yes.
the
Now,
organizers. It
now
says
I'm
to
going to
ask.
make you the presenter.
Okay.
Please accept that.
What do I have to do to accept? Share my screen.
Choose.
Yes.
Now share.
Okay.
Yes. Now I can see your presentation.
Okay. Now I'm going to start my slideshow.
Yes.
I'm sorry that took so long. My name is Molly O'Brien. I'm an honorary
Dr.
associate
Molly,
professor.
Dr. Molly, can you wait a minute?
Yes.
Yes,
Yes.
your
I
PPT
can
got
wait.
disconnected.
Okay. My PowerPoint was disconnected.
Yes, I can
Now,
see your presentation.
so can I press share again?
Yes,
Share screen.
yes.
Screen. Now share. Now you can see me and you can
Yes,
see my
I
PowerPoint.
can I can see your
Tell me,
PowerPoint. Can you make it a slideshow?
I am trying to do that. Last time I did it, you said it disconnected. Now has it disconnected?
No, you can start your
Okay.
presentation.
Okay, I'm sorry that took so long. This is
It's
my
okay,
first
it's
time
okay.
using GoTo. And my name is Molly O'Brien, and I'm an honorary associate professor at the ANU College of Law. And the topic of my talk is how physicians, nurses, and staff can train families, police, and lawyers. And the subject of my talk is about acquired brain injury or traumatic brain injury and how those people with those injuries are overrepresented in prison populations. Compared to the general population, people in prison are more than 5 times as likely to have had a brain injury. And in Australia, something like 46% of the people in prison have had have an acquired brain injury, but it's not just an Australian problem, it's a problem around the world. Acquired brain injury or traumatic brain injury is overrepresented by 50 to 80% of the prison population in the US, 65% of the prison population in the UK, and 50% in New Zealand, 50% of the prison population. Also, not only are they overrepresented, but the prisoners' traumatic brain injury is more severe than the traumatic brain injury of the general population. 81% of the 9% of the people in the general population have had a mild brain injury, but only 65% of the injured prisoners have had a mild brain injury. 11% of the general population with brain injuries have had a moderate brain injury, but 13% of the prisoners have had a moderate brain injury. 8%, only 8% of the general population with a brain injury has had a severe brain injury, while 13% of the prison population with traumatic brain injuries have had a severe brain injury. And that usually um, corresponds to a long period of being unconscious and many remaining side effects. Although you may have side effects after you've had a mild or moderate brain injury, the most common side effects are from severe brain injuries. Having a brain injury makes it more likely that you will be homeless, have a drug addiction, have a mental illness, including depression, be suicidal, be aggressive or violent, or be unemployed. People with acquired brain injury may have difficulty accessing legal aid. They may have a restricted understanding of how to exercise their rights. They may have difficulty understanding court procedures. They may have poor impulse control and or aggression that get them into trouble with the law and with their friends and family. And they may have poor memory about court times or pretrial appointments, events on trial, their own conduct, or the extent of their own injuries. So what should we do? Well, the first thing we should do is engage in better diagnosis and identification of people with acquired brain injury. We should have better support for those people. We should have training for police and defense lawyers to improve acquired brain injury literacy. I know that when I was a defense lawyer defending poor accused people, I had no training at all. And we should have a more therapeutic approach to their time in prison and to their treatment and placement on release. And I have borrowed those steps from a piece called I'm Not Drunk, I Have an ABI, which is a very good article. I recommend it. And you can get it on psychiatry, psychology, and the law. But it's really incomplete because there are more things that we should do. We should have better assessment of ongoing symptoms or functional problems. We should have assistance to traumatic brain injury patients to help them cope. And specifically, we should have link workers to assist people with traumatic brain injury to help them develop memory aids, reminders for appointments, and to encourage engagement and rehabilitation plans and strategies to manage their emotions. And this is something that the UK has done already. There is an organization called Headway where you can get a brain injury identity card so that people with a traumatic brain injury won't be wrongly arrested or can get support if it is needed. And Headway actually has a video of a person who was arrested 3 times, but the third time he had a brain injury identity card so that the police officer didn't think he was just being rude, but could understand that he had a brain injury, and that explained his slurred speech and his interrupting and so on. So, what can doctors, nurses, and staff do? Well, doctors, nurses, and staff know the many deficits and problems that face people who have an acquired brain injury, and they can share their strategies. Medical staff can give their knowledge and experience in dealing with people who have an acquired brain injury to the police, to defense lawyers, to judges, and to families. You should know that in most places, including Australia, when someone is suspected of committing a crime, they generally are not screened for traumatic brain injury or acquired brain injury. They are screened in the UK, but they may not have been diagnosed with an acquired brain injury or traumatic brain injury, and they may suffer from anosognosia, which involves ignoring, denying, or disbelieving that you have an injury. And I suffered from that myself. I'm going to talk about my brain injury a little bit later, but one of the things that I recall now specifically was that I did not think I was injured. Currently in Australia, screening is not done and there is no training for defense lawyers, and only a little bit is done by a few of the jails and prisons in Australia. People with undiagnosed acquired brain injury may have to self-represent in court. The numbers of incarcerated people with unidentified acquired brain injury are increasing. A person with an unidentified acquired brain injury may be unable to comply with sentencing orders and may not be able to desist from further offending. And you should also know that sometimes people get a traumatic brain injury while they are in prison or while they're on the street being arrested. They hit their head on the concrete and get an acquired brain injury, and it may not have been diagnosed. So undiagnosed and unscreened people might not be referred for special programs. They might forget court dates, and they might not raise important issues. Even if a person has been diagnosed, a service provider in Melbourne prison told me there is no special unit in the prison for acquired brain injury clients and no programs that I can think of that have been specifically designed for acquired brain injury prisoners. That was off the top of his head, but medical staff do know which of their patients will have trouble with the law. So what can they do? Medical staff do know which of their patients have low self-control, poor memory skills, and the tendency to act out violently or to disagree loudly and vocally. This is a picture of me when I had a brain injury, which happened after a bicycle accident. And medical staff saw me when I was in a coma for 68 days. And they also saw my friends and family. Here are my parents, my husband, my 2 boys, and my friend Sigrid, all who came to support me while I was in hospital. And when my friend Sigrid was visiting me in hospital, I was too ill to walk or to eat, but I thought I was fine. And when she came into my room, I told her I was ready to go home. And she said to me, "No, you're not ready yet. You can't go home yet." I told her I had packed my things and I wanted to leave, and if she didn't let me leave, I would punch her. Well, she sat down on the floor and started to cry. And a nurse heard her crying and came in, and the nurse assessed the situation, realized that I was being unreasonable, and distracted me by taking my pulse and my blood pressure, and she talked to me about the things that had nothing to do with staying or leaving. So she distracted me. She had seen this kind of situation before, and she knew what to do. So medical staff have the experience, the strategies, the practice, and more knowledge about acquired brain injuries, patients' problems, and the possible tactics to solve them. Medical staff should assume that all of their acquired brain injury patients may have trouble with the law, and the medical staff should reach out to patients, families, and friends, because families and friends do not know how to deal with a disagreement with an acquired brain injury patient. Like my friend Sigrid, they just collapse and want to cry. They figure, I can't deal with this. But they need to know the full extent of the patient's memory difficulties and the fact that they may be irritable and aggressive sometimes. And if faced with a disagreement with a person who has a brain injury, the family and friends may not know how to distract that person and proceed. It's not about confrontation, it's about distraction and getting things done. So families and friends of acquired brain injury patients may not be aware of how to get things done the way hospital staff knows. So hospital staff have practice getting things done with patience and a smile, with distraction, by writing instructions to the patient, by reminding them of things, by ignoring the crazy things patients say. And that's so important. If a person shouts out something and it's just crazy, you know that you can ignore it and move on with patience and a smile. And by taking time to get a grip on yourself before you interact with that brain injured person. In other words, it's not you or something you said. What might be happening has to do with what's going on inside that brain injured patient's own self. So you need to be able to get things done with distraction, instructions, patience. And you should teach the patient's family and friends, because they may feel harassed, frustrated, disappointed. They may be at a loss to know what to do. They may feel unwilling to persist or insist or withstand unreasonable disagreement, and they lack your training and practice. So training and information, you should know that those are not readily available to the public. So the medical staff, the professional staff, needs to share. And medical staff should let families, friends, and patients know that a patient may be impulsive, unreasonable, violent, or forgetful because of their injury. In other words, it's not something that the family or friend did wrong. It's something that happens to the brain injured person. And the family and friends need to know that that is all right, that the brain injured person may need someone to help them in the future. Medical staff can and should teach patients, families, and friends where the treatment options and support options are available In the UK, there's Headway, and Headway can provide a brain injury identity card, and they also have notes that the Sentencing Council has guidelines for sentencing people with brain injury. So you can read what those guidelines are, and those guidelines refer often to medical information that the courts need so that they can consider what might be going on with this person who has an acquired brain injury. Also in the UK is the Cambridge Centre for Pediatric Neuropsychology Rehabilitation, and that is a multidisciplinary center that deals with teens, so people who are not yet adults who have had a traumatic or acquired brain injury, and that center helps those patients deal with their emotions, with their language problems, with their medication, with their body movement, and with their education. And it's very important that a multidisciplinary approach be taken to the treatment of the problems of an acquired brain injury patient, because they may slur their speech, they may have trouble moving, they may drop out of school, they may become drug addicted. All kinds of things can happen if they're allowed to happen. So medical staff and professionals should refer patients to that center. And doctors, nurses, and staff can also talk to patients, family, and friends. Tell the family and friends to write down the patient's appointments, and tell the patient, take the patient to the correct courtroom at the right time. That sounds kind of Mickey Mouse, but quite a few brain injured people miss their court dates or show up late, and judges do not like when that happens and issue warrants for arrest that send the brain injured person straight to jail, and that's what we want to avoid. Medical professionals can help develop programs and approaches that specifically assist accused people who have an acquired brain injury and need more support to attend and comprehend proceedings. So they may just need some hand holding. The person with an acquired brain injury may just need someone with them to explain things to them. And in the UK, all offenders are screened using the Brain Injury Screening Index, and positively identified offenders are given a link worker who delivers person-centered rehabilitation and develops partnerships with health, probation, homeless, and drug, alcohol services to make sure that each offender has an appropriate network in place. Now, that network can be very important, but it is also important that that person's family and friends understand why they need that network. What is the purpose of having all of those people lined up to assist? And just so you know, screening in Australia either doesn't happen or happens too late. So doctors, nurses, and medical staff can provide families and patients with a list of common ongoing symptoms, with the contact name of someone who can help the patient out. That could be their link worker if they're in the UK, and provide them with the fact that most brain injured people need help at some point, and that is all right. Brain injury symptoms are not static. They increase and decrease from time to time. So at some moments, the brain injured person may need a lot of help, and at other times, they're just fine on their own. You need to make sure that the families and friends of the person with the brain injury knows that, and know that it's all right to reach out for help. And let those families and friends know that they should distract the patient rather than disagree with the brain injured person. And everyone should understand that brain injured people often feel that there is nothing wrong with them and they do not need assistance when they really do. And I'm remember that some ethnic minorities also find that there may be a stigma attached to them if they carry the label of brain injury or needing mental help. So you need to be sensitive to that complication so that having a brain injury isn't viewed as a stigma, but is viewed as a point from which a person can get the support that they need. And the brain injured person and their family need to know that recovery from a brain injury may take years and years and years. My brain injury occurred in 2012, and so it's been quite a few years, but since I had a brain injury, but I feel I am still recovering and I still see symptoms in myself. So I will take your questions, but while I listen to your questions, I wanted to tell you that I've written a book about my brain injury and recovery, and if you wanted to order a copy of it, you could go to nobodyhomebook.com and order a copy, and I will put one in the mail to you. It talks about how I was injured, how I recovered, and how I made my way back to teaching again. And now, let's see. Are there questions?
Thank you, Dr. Molly, for your great presentation.
Thank you. I'm
Does anyone
turning
have any
off.
queries? Yes, you can turn off your screen.
Okay. Let's see. I don't want to share anymore.
Yes.
So pause sharing. Okay. Now I've turned off my screen. Oh, it's paused. I don't know what that means. Anyway, I would take any question.
Yes. Does anyone have any queries? I hope there are no queries. Benjamin. Benjamin have query.
Okay. Benjamin, is it on chat?
No, I think, can you hear me now? If you can hear
I
me,
can hear
I
you.
would like
Yes.
that to be on audio. Thank you very much for the very lucid presentation. And I appreciate so much that it's even coming from a personal experience from you. Now, I have a question. I've been with patients who had suffered traumatic brain injury from an auto crash, but it was in a psychiatric hospital. So now I want to know, how soon do we expect patients to recover? Because, um, after being treated at the hospital, they're still going to have a long way in their life, maybe at the places of work, in their relationships, and in the society. So, how long do we tag an individual at being brain injured and having immunity towards, let's say, crimes or towards punishment for criminal activity? Because I understood that you spoke from the aspect or from the perspective that patients who had suffered, let's say, head injury could have a problem with their limbic system, and that could make them very aggressive and not have cultured behavior.
Okay, you may know
Give
this
them
already. Should I answer now? Okay, the
hello.
recovery is fastest and most dramatic during the first 6 months of after the brain injury. So when I was brain injured at first, I was paralyzed on my left side, and that paralysis lasted several months. But by 6 months after the brain injury, I was no longer paralyzed on that side. On the other hand, I didn't have memories. I could talk to people um, a little bit, and I made sense. Like I told my friend Sigrid that I was ready to go home, and I was sure I knew what I was doing, but I didn't know what I was doing. And I couldn't form any new memories. I showed you a picture of when my parents came to visit me in the hospital, and they sat by my bed for 2 weeks, and then they went back home, back to the US. And I could not remember that they had been there. I couldn't remember. And I only became convinced that they had been here when I got out of hospital and came home to my house, and I saw that the rose bushes had been cut. So I knew that my husband Charlie didn't cut roses. So I knew it was my mother who had cut them. And I I think that my memory began working again uh, about 9 or 10 months into the recovery, but it's still not what it should be. So now there's another hand raised.
Okay.
Uh,
Apologies for that.
let's, Mr. Ofori, your microphone is not on. Is your hand raised, Mr. Ofori?
Yes, please. Can you hear me?
Okay, yes, I can hear you now.
All right, all right. Thanks for the presentation. I think it's a very nice presentation. I've really enjoyed your presentation, madam. Okay, so my
Good.
question is the long-term outlook for people with acquired brain injury varies depending on the severity of the injury, on the individual's response and the individual's response to treatment. But my question is, can people with acquired brain make a full recovery?
Yes, some some people have uh, acquired brain injuries that are mild or moderate, and they have full recovery. although
Okay.
some people with mild or moderate brain injuries have ongoing symptoms. Now, if you have had a severe brain injury, your recovery depends a lot on what part of your brain is injured. So that if it's the temporal region of your brain that's injured, you may become more impulsive and more likely to be violent. And some people have irresistible violent impulses after a brain injury that have nothing to do with their pre-existing personality. This is just a brain injury symptom, and it's like a trigger. Like once it's pulled, they have a violent outburst. Now, for some people, those can last just a few months or even a few weeks. And for other people, it's a lifelong thing. And they may not know what it will be that will trigger that violent outburst. So those people with those types of acquired brain injuries need some kind of strategy to deal with their impulses, their violent impulses, so that they don't hurt anybody, so that they don't murder somebody, so they don't break their house down. They need a strategy because they don't know when it will happen to them. And it will come to them like a surprise, and they need to have already figured out what they're going to do about it. In other words, they need to know that that's the moment to drink a glass of water or sit on the floor or call a friend. In other words, the strategies will be different for each individual, but they may need a strategy and it may be lifelong. Does that answer your question?
Yes, please. Thank you very much.
Sorry about that. Sorry I didn't say, 6 months. Oh, I should tell you that most of the literature about brain injury talks about the first year of recovery, and some talks about 2 years. But
Okay.
my experience has shown me that for many, many people, there are symptoms that continue throughout their lives.
Oh,
And
all
so
right.
it's not a short term thing, it may be a long process. Who's got their hand raised now? I think it's Benjamin again.
I do have a question at your private message, so you can just openly respond to that. A chat.
Okay,
Thanks.
I'll look
Yeah.
at that. Is there anyone else with a question? Um, I don't see the question in the chat, but Emma, I think it's back to you. Thank
Yes.
you.
Does anyone? Yes. Thank you, Dr. Molly, for your wonderful presentation.
Okay,
I hope there are no more queries.
I don't think so.
Yes. Thank you. Now let's move on to next presentation.
Okay,
Let's move on to next presentation by Mohammed Hanan from Hamad Medical City. Qatar. Title of the presentation is Cauda equina syndrome from a neuroradiological perspective. Dr. Mohammed, are you ready with your presentation? Dr. Mohammed? Dr. Mohammed, are you there?
It seems like it takes a little while to get the go-to thing to work on your own computer.
Yes, yes.
I will leave it to Dr. Mohammed.
Thank you, Dr. Moli. Dr. Mohammed, I can't hear you. Can you hear me? Dr. Mohammed, are you there? Yes, Dr. Mohammed, I can see you. I have made you the present. You can now present. I can't hear you. I can see your presentation, but I can't hear you. I can't hear you, Dr. Mohammed. I can see your presentation. I can't hear you. No, I can't hear you. Can you please check your sound system? No, I can't hear. Can you please exit and then join again?
Hello, hello, can you hear me now?
Yes, Dr. Mohammed, I can hear you. You can start
Excellent,
your presentation now.
excellent. Thank you. Thank you.
Yes.
I will just okay. So my presentation is about the Coda equina syndrome and
Dr. Mohammed,
from
can you wait a
yes.
minute? Can you please make it? Yeah, you can continue.
Okay, excellent. Yeah, okay. So it's about the Coda equina syndrome from radiological perspective. And I'll start with as you know, the Coda equina in Latin language means the horse tail, and this exactly represents the appearance of the nerve roots within the lumbar spine. As you can see here, can you see the cursor of my mouse here? Is it Is it possible you can see it, or you can't see it? I don't know. Okay, anyway, so you see this yellow tail, what looks like a plexus here is the nerve roots in the lumbar spine. So in MRI, this the MRI of the lumbar spine showing the coda equina nerve roots. You see this dark lines here in this within the thecal sac. This is the coda equina nerve roots. It's arising from the lower part of the spinal cord here at the D12L1 level, and then as it goes down along the lumbar and sacral spine. These dark lines represent the coda equina nerve roots. In axial section, as you might see here on the right side, you see these nerve roots appearing as dark dots within the thecal sac, which appears bright. So here another images, another MRI for the lumbar spine. Normal anatomy. You can see this vertebral bodies here. Number 2 is vertebral body L3. And number 3 arrow indicates the intervertebral disc between L3 and L4 in normal patients. So, and this bright or white area within the spinal canal, this is the spinal canal. And this white area is the CSF fluid within the thecal sac. And these, again, the nerve roots within the thecal sac. As we move laterally, we can see one of the nerve roots exiting through one of the neural exit foramen. Can you hear me now? Yeah. And this above this nerve root is the pedicle. And so just to make sure that, yeah. Okay, so back to, yeah, okay. The coda equina syndrome is a relatively rare clinical condition. And what we mean by clinical condition is that it's usually diagnosed based on clinical findings. Coda equina syndrome produces characteristic set of clinical features and is surgical emergency requiring urgent intervention. Otherwise, permanent damage to the nerves can occur. Definition. There is no consensus definition for coda equina syndrome. However, the dysfunction occurs usually of the nerve roots at S2 level and below. And in most of the cases, it's due to mechanical compression. Epidemiology, it occurs in approximately 1 in 65,000, according to one study. And it's seen in our practice in radiology in around 3% on the lumbar spine disc herniation. Etiology, the coda equina syndrome can occur due to a list of causes. And usually this is caused by significant spinal canal stenosis, which is the main finding in radiological investigation, and mechanical compression of the coda equina enough to produce symptoms. The commonest cause is disc herniation. Other less common causes: neoplasm, trauma, hematoma, abscesses, and inflammation. Here is the list of the main causes, starting with disc herniation, which is the commonest, by far the commonest cause of coda equina syndrome. The next cause here is trauma, then tumors, infection, hemorrhage, ankylosing spondylitis, iatrogenic. We'll start with cause number 1, which is the disc disease. As we said earlier, it's the commonest cause for spinal canal stenosis and coda equina syndrome. Disc herniation, what we mean by disc herniation is posterior displacement of the disc material, like a nucleus pulposus, which is part of the disc, and annular fibrosis and cartilage beyond the limit of the intervertebral disc space. In this diagram, we can see the difference between the normal and diseased disc. On the left side, we can see the normal disc. You can see here the blue disc and the posterior concavity. And the posterior part of the disc, there is normal concavity. And we can see the thecal sac patent wide and the nerve roots, which appears green in color here, within the thecal sac moving freely. In case of diseased disc, for example, bulging disc, there will be loss of this posterior concavity of the disc, and the nerve roots will appear in close relation to each other. They appear close to each other, almost sticking to each other. So in this case, there is a spinal canal stenosis. We have different types of disc herniation, whether diffuse or focal. In case of diffuse, as we can see here in figure B, you can see the entire disc is displaced posteriorly. And as we said, there will be loss of the normal concavity seen in the posterior part of the disc. In the figure C, as you can see, there is focal displacement of the part of the disc posteriorly. In this case, we call it protrusion, as we might say, and usually it has a broad neck. This is the first form of the focal displacement or focal herniation of the disc. Figure D is the second form of focal disc herniation, which is extrusion, where there is a break in the annular fibrosis, and the disc material is extruding through this break into the thecal sac. And when there is loss of contact of the extruding disc with the mother disc, we call it sequestration. And usually it falls within the thecal sac and the dependent part due to gravity. Coda equine disc bulge, commonly associated with other factors, which can make things worse even in this. I will talk about later on. So we have a first example, case number 1. This is an example of coda equina syndrome caused by disc herniation. 39-year-old male patient complaining of more than 1 year history of back pain, presented to emergency department complaining of tingling sensation in the pelvis and thighs with acute urinary retention since 1 day. You can see here in MRI in the sagittal plane on the left side, this disc bulging, and there is disc material is extruding and migrating inferiorly, almost completely filling the sagittal diameter of the thecal sac. You can see above it the white CSF fluid and below it the CSF. And at this level, this disc material is compressing the nerve root. You can see this nerve root above it, and then it's completely compressed. It's completely gone at the level of the disc extrusion. In the axial plane, you can see this small disc posteriorly, and as we go down, you see more part of the disc. This is disc material migrating inferiorly, and this tiny dark area posterior, just posterior to the disc, is the thecal sac tightly compressed. And this is the cause of the symptom, and this patient had an emergency surgery. The second cause of coda equina syndrome is the neoplasm, which could be either primary or secondary. Primary, the commonest neoplasms at this area which can produce the symptoms and the syndrome is the myxopapillary ependymoma, schwannoma, meningioma, and also the secondary, which could be either from CNS in the form of drop metastasis or from outside CNS, commonly lung and breast cancers. Case number 2, which is an example of syndrome caused by a neoplasm. 34-year-old patient with lung cancer with 2 weeks history of back pain, presented to emergency department complaining of new onset of sudden anesthesia, urinary and stool incontinence. Physical exam shows lower limb weakness. Here on the left side, we can see sagittal image of the CT scan one window. You can see here a large sclerotic lesion in the L5 vertebral body as appears as a white area, and multiple other smaller lesions in L4 and S1 vertebral bodies. When we do MRI, this is T1 MRI, you can see this sclerotic area appearing as area of low signal intensity, and we can see a mass lesion in the anterior epidural area just posterior to the vertebral bodies. You can see here in this T1 and on T2, this mass area almost completely facing the thecal sac. You can hardly see the thecal sac. It's just only appear as thread-like area of high signal intensity, bright signal intensity. And you can see above it, you can see the fluid, and below it you can see the fluid. And then in the axial section, you can see this mass lesion in filling the thecal sac and completely tightly compressing the thecal sac. And the third case here is the third cause of this syndrome is trauma, and usually occurs after burst fracture with retropulsion of the vertebral body. And this is the case number 3, an example of syndrome caused by trauma. 35-year-old male patient sustained multiple fractures after fall from height, complaining of severe back pain and urinary retention. CT showed burst fracture of L4 vertebral body, encroaching on the spinal canal. MRI revealed compression of coda equina by the displaced bone fragments. In CT scan here, on the left side, you can see the sagittal bone window CT scan of the lumbar spine. You can see this burst fracture of the L4 vertebral body, and with completely detached posterior parts encroaching on the spinal canal. You can see here this patent spinal canal, bone spinal canal above this level, and at this level, this bony fragment is projecting in the spinal canal. On the axial section, you can see this area, how narrow is the spinal canal. In MRI on the right side, you can see this burst fracture of L4 vertebral body with bone marrow edema and blood, and retropulsion of this posterior part completely effacing the thecal sac. And you can see again the thecal sac above this level and below this level, where you can see white CSF. And at the same level of the fracture, it's completely compressed, and the nerve roots, you cannot appreciate the nerve roots. At the axial section here, you can see this again, the vertebral body, and with this dark area is the compressed coda equina nerve roots. The fourth cause of coda equina syndrome is infection, which could be either tuberculous or pyogenic in the form of abscess with phlegmon, usually compressing the coda equina. And here, case number 4, which is an example of syndrome caused by infection. 50-year-old diabetic and hypertensive male patient presented to ED complaining of acute back pain and lower limb weakness with urine retention and perianal paresthesia. Patient was febrile. Blood test showed significant leukocytosis. Here in MRI, this is post-contrast T1 images. You can see enhancement here of L5 and S1 vertebral bodies with soft tissue lesion in the anterior epidural area just posterior to L5 and S1 vertebral body, and causing a significant spinal canal stenosis at this area. And again, you can see this dark area is the compressed nerve roots, for the equine nerve roots. And number 5, the cause number 5 for the syndrome is spondylolisthesis, facet joint arthropathy, and facet joint arthropathy and hypertrophy of the ligamentum flavum. Usually, these degenerative changes occur in association with disc bulge in most of the cases. As we can see here, there is already disc bulge, and there is significant thickening of the ligamentum flavum here, this dark area, and facet joint arthropathy appearing with joint effusion here and osteophyte. You can see this coda equina and thecal sac compressed between the disc and the hypertrophied ligamentum flavum. So And the symptoms and signs which make the diagnosis here, as we said, is a clinical condition. So symptoms depend on grossly on the degree of compression and the nerve roots being compressed. The following are the symptoms seen in Coda equina syndrome: lower back pain, unilateral or bilateral leg pain, sciatica, unilateral or bilateral lower limb weakness, saddle anesthesia. This includes perineal and perianal areas as well as inner thighs. The severity of the sensory disturbance correlates with the number of the involved nerve roots. And number 5, bladder, bowel, or sexual dysfunction. The latter two are only rarely seen. Although all these symptoms can be seen in Coda equina syndrome, the latter two, 4 and 5, which means the sudden anesthesia and then bladder, bowel, or sexual dysfunction, are the hallmarks for definite diagnosis. The Coda equina syndrome usually presented in 3 forms. Acute can be acute, which is rare, and the commonest presentation is acute on top of chronic, and then chronic presentation with a gradual deterioration of the patient condition. For investigation, we usually, as we said earlier, Coda equina syndrome is a clinical condition, diagnosis based on clinical appearance. However, the imaging rules can play an important role in detecting the cause of this condition. We'll start with MRI, which is the modality of choice. And in vast majority of the patients, MRI will be enough to reveal the cause of this syndrome. And the main finding in MRI will be the spinal canal stenosis. We graded the spinal canal stenosis in MRI into 3 degrees. First, grade 1, which means mild stenosis, grade 2, moderate, and grade 3 is severe stenosis, depending on the degree of the nerve roots aggregation. We can see here on the top left image, you can see the normal appearance of spinal canal where there is no stenosis. You can see this disc and this thecal sac, and the anterior part you can see this white fluid, and at the dependent part you will see these multiple dark spots which represent the nerve roots and the axial section. In cases of a mild or first degree spinal canal stenosis, you can see the nerve roots coming close together to each other, and you can see, but you can appreciate the CSF space in between. In cases of moderate or second degree spinal canal stenosis, they come further together, close to each other, and you can hardly see the CSF in between, but you can still see it. But in cases of severe, as seen at the right side, you see the spinal canal, you see the thecal sac and Coda equina nerve roots as one block, one bundle. You cannot appreciate the nerve root from the other, and there is no CSF in between. CT scan is good alternative when MRI is contraindicated. It's very good in assessing bony tissues and bony spinal canal stenosis. CT scan can highly exclude Coda equina impingement if the thecal sac is effaced by less than 50%, as one study concluded. The possibility of CT scan to identify soft tissue lesions can be sometimes limited by artifacts, which commonly seen during our practice. Myelogram is becoming less practical in the presence of MRI. It's relatively invasive because it requires intrathecal injection of contrast. Nerve conduction studies and electromyogram. These are 2 electrodiagnostic tests frequently done together to assess the functional integrity of the targeted nerve. Therefore, the degree and extent of nerve damage. They are usually done complementary to MRI and not required in all patients. The treatment depends on the underlying cause, whether conservative or surgical. Here is a diagram proposed by one of the centers of NHS in UK for management of the Coda equina syndrome. And so the take-home message here is Coda equina syndrome is a serious clinical condition, can result in significant morbidity if not treated in time, and has multiple causes. The commonest is disc disease. MRI is the modality of choice for diagnosis. Here's an image for a Palestinian woman embracing the body of her child who was killed during the war, recent war. Child looking at the body of his dead mother, again in Palestine, Gaza. Thank you. So, any questions?
Thank you, Dr. Mohammed. That was a wonderful presentation. Does anyone have any queries?
Hello, can you hear me?
Yeah. Yes.
Hello, Dr. Mohammed. Thank you for your presentation. I have a question related to the treatment. In early stages of the syndrome, which is the best treatment that you could consider, or it depends on the patient?
Yeah, thank you for this nice question. Actually, it depends on the. I'm not a neurosurgeon actually, but from our experience, it depends on each patient is different case. So, but in cases of severe condition where there is the patient presented within 48 hours to the emergency, the treatment usually is surgical, and to serve what we can save, because 48, some studies show that the surgical treatment within 48 hours can have a much better prognosis than patients treated after this 48 hours. 48 hours you can still do something. After this it's maybe too late. So, but some patients with milder degree of this syndrome respond well to the conservative and physiotherapy treatment.
Okay, thank you very much.
Yeah, welcome. Yeah. Yeah. It's okay.
Dr. Mosley, do you have any query? I think Dr. Mosley have a query.
Yes. How can I receive his? I mean,
he just raised his hand.
Yeah. Okay. Yeah. Yeah.
Dr. Mosley, can you hear me?
Hello?
Yes.
Yes. You raised your
You hear me?
hand.
Okay,
Yes, I can hear you.
thank you. So just I ask Dr. Mohammed if there is any genetic cause in this disease, associated with the disease.
So far, there is no evidence for this, but who knows? Maybe in the next future. I haven't been through an article about this, the possibility, but nothing so far as far as I know. But who knows? Maybe something will come soon.
Okay, thank you. You talked about a lot of techniques and methods to diagnose this disease. But in case of infection, like tuberculosis infection, what's the main method to detect the cause in this case?
Okay, it's all together. We start with the MRI to diagnose that there is Coda equina syndrome, or there is significant spinal canal stenosis, And then lab tests like quantiferon test is positive. I mean, in the cases of TB, it's very, very sensitive exam, quantiferon. And some altogether chest x-rays sometimes can show an evidence of tuberculous focus in the lung. So we depend on all these together, the lab findings and the radiological findings.
Thank you, Dr. Mohammed.
Thank you.
Thank you.
So any more questions? Okay, so yeah.
Thank you.
Thank you. Thank you very much. Thank you. Take care.
Next presentation is by Dr. Majid Mosley, CHU Nimes, France. Title: Real-time metagenomics-based diagnosis of life-threatening community-acquired meningitis. Dr. Mosley, are you ready with your presentation?
Yes. Can you give me permission to share my screen?
Yeah, now I'm making you the presenter.
Okay, thank
Please
you.
click on your screen.
Do you see my screen?
Yes, I can see your screen.
Is it okay?
Yes, you can start your presentation.
Thank you. So I'm Majid. I'm from University Hospital of Nîmes. I'm technical head of micro and bio platform focused on sequencing genomics and metagenomics, specialized on microbiology and infectious diseases. So today I share with you my experience about the improvement and the new implementation of new tools at the point of care laboratory about the direct diagnosis by real-time sequencing of cases of life-threatening community-acquired meningitis. As you know, community-acquired meningitis is a part of CNS diseases, and it's a life-threatening condition whose prognosis depends on the causative pathogen genotype. At least 1.3 million cases reported every year worldwide, which present between 30 and 50% of central nervous system diseases. Usually, virus infection is associated with meningitis, but bacterial meningitis is the deadly form of infection and usually caused by four principal actors, including streptococcal pneumoniae, Neisseria meningitis, Haemophilus influenza B serotype in a lot of cases, and Listeria monocytogenes in old patients. And in infants and neonates, Streptococcus B group is the most infection detected in this category of patients. In 2020, more than 290,000 cases of deaths reported worldwide, which estimated of 50% of the bacterial meningitis cases. So, at least 200 pathogens were involved in CNS diseases, and mostly meets at virus infection followed by bacterial infections. In rare cases, the fungal infections, and in very rare cases, the parasite infections. In Europe, the most documented etiology associated with meningoencephalitis and meningitis is enteroviruses. And only in 2018, more than 4,700 cases were reported in 15 European countries. According retrospective analysis in our hospitals. From the total admitted cases at the emergency department, only 4,000 cases were documented, which present less than 7% of the total cases. And many epidemiological events were recorded, but remained of unknown causes. And this motivated us to do a comparative investigation between two university hospital centers in southern France, in Nîmes and Marseille infectious disease department. And in both patients and both centers, not exceed 11% of positive cases recorded, and mostly represented by a viral infection and bacterial infection. And in total, 62 pathogens were detected in this series. This may be due to the routine investigation and routine tools used for the diagnosis of this disease, based on the direct examination and the limited target of pathogens using filmary panel, and the culture, which limited to the bacteria viability and the disponibility of medium. And the molecular tests are very limited by the specific target of the pathogens. And in some cases, culture could make very long time to the characterization of the microbe, which very limit the which limit the patient management and the good prescription of an adequate treatment. According to literature review we performed, we find the metagenomic. Maybe it's a good way to detect the directly the pathogens from cerebrospinal fluid samples. And at least 116 pathogens detected directly by metagenomics, but using all routine tools, this number not exceed 60 pathogens identified by molecular and culture routine methods. According to this overview, we met three biggest limit in routine diagnosis. Firstly, the very big number of meningitis of unknown etiologies, and the difficulty to genotype correctly the pathogens, and the time consumed, and the limited number of pathogens investigated in routine. What can do to resolve this? Maybe we can improve the pathogen genotyping using new tools, maybe genomic tools. The introduction of real-time sequencing maybe help to go speed to the detection of the pathogens and the total characterization of these microbes involved in central nervous system infections. And why not to document or to reduce the number of meningitis of unknown etiologies? We started with enteroviruses because the first etiology detected in Europe. Enteroviruses are small virus, arenaviruses, reparted on 15 different species, and at least 116 serotypes associated with human infections, and 30 serotypes were involved in central nervous system infections till today. Usually, enterovirus infections are benign, except some serotypes, including D68 and I71, which may be at the origin of very severe form of meningitis in neonates and child. So, to improve the enterovirus detection, we supposed two strategies. The first one is to enrich the viral genome, and the second one is to limit the number of the fraction of a human genome in the sequenced sample. So to enrich the enterovirus genome, we developed an in-house protocol based on genome amplification with multiplex PCRs, followed by Illumina sequencing. Using our approach, we detect ecovirus serotype 9 with more than 4 genome coverage, while in routine, based on 300 sequencing target, the genotype is given as equivirus 7. This may falsify the final result and the final characterization of the pathogen. In the second case, we try to remove the human genome from the sequencing samples, and we developed one protocol including RNA extraction and DNA treatment, cDNA synthesis, and the sequencing in Illumina ISAC platform. For the first time, according to the literature, we document meningitis in neonate sample associated with equivirus 12 genotype. While in routine, the identification based on 300 PCR target equivirus 9 genotype. This completely different when we compare the both results. And this result was confirmed by phylogenetic analysis based on the whole genome sequence, which was published in Pathogen as a case report documenting the first case of equivirus 12 meningitis. So using the Illumina platform, maybe we can improve the viral detection and the antivirus genotyping. And we detected for the first time a case of meningitis associated with equivirus 12 genotype. And we have a very powerful protocol to sequence RNA viruses and from the clinical sample. But the limit is the time. It's exceed 24 hours. What we can do to surpass this limit, maybe the real-time sequencing using Oxford Nanopore technologies tools may answer for this question. Using Me9, we developed one protocol not exceed 4 hours workflow, including the DNA extraction, library preparation in 1 hour time, and sequencing during 2 hours run. As you know, Oxford Nanopore strategies based on the sequencing of single-end sequences without prior amplification, without amplification. And the sequencing is based on the detection of difference of electrical potential when the sequence, the single strand sequence, but through the synthetic protein parts. So we started with a few cases to validate our approach. The first case, in less than 6 hours run workflow, we detected non-typable Haemophilus influenza genotype susceptible to all antibiotics used in routine in a patient immunized against influenza B serotype, Haemophilus influenza B serotype. And the utility of this case, either we are immunized against specific genotype or serotype, this not a region do not be infected with another genotype, not routinely detected or routinely documented. And these results were confirmed 2 days later by routine procedure. But in this case, in less than 2 hours, including only 20 minutes sequencing run, we detected, we recovered the quasi-totality of pneumococcal genome from cerebrospinal fluid sample, genotyped as 10I genotype susceptible to all antibiotics. And this result was confirmed by the routine procedure 2 days later. But in this specific case, 80 years old woman was admitted at the emergency department for meningeal syndrome, very severe meningeal syndrome, and all routine tests remained negative. And when we work this sample with our strategy, after 30 minutes run, we detected the Pasteurella multicida genome in the cerebrospinal fluid of this patient. And this was confirmed by two positive blood culture of Pasteurella multicida. And when we investigate the clinical records of this patient, we find this patient had been bitten by her domestic cat 1 week ago, which confirmed the zoonotic transmission of Pasteurella from the cat to the patient. And based on these fantastic results, we implemented at the point of care laboratory in two university hospital centers in southern France the real-time metagenomics platform. So we developed a specific strategy based on the direct sequencing of the cerebrospinal fluid samples after DNA extraction and the analysis in real time of the generated sequences. So the real-time analysis based on two strategies. The first one is to blast all the generated reads against an in-house database created in reference to Filmary panel. And in second time, to do not escape for any potential infection or any potential genomic, viral genomic or pathogen genomic sequence in the cerebrospinal fluid, we have to blast the results against NCBI GenBank database. And to remove all cross-contamination potentially generated during the manipulations, we add a barcoding step to our protocol. So the direct analysis of the generated data are as follows. Firstly, we have to blast directly the generated reads against an in-house database and the online accessible database. And in second time, for all positive samples, we have to recover the specific genomic sequences for further analysis, including genotyping and prediction of all gene encoding for antibiotic resistance and virulence. We investigated 52 cerebrospinal fluid samples from patients with meningitis. After 20 minutes run, 70% of cases detected as positive for infection, for viral and bacteria infection. And after 2 hours run, 47 on 52 were detected as positive. Supplementary pieces of information were added based on whole data generated analysis. And we detect only two discordances in reference to Fermale results. The first one is false positive generated by the Filmary analysis for Haemophilus influenza, and the second one is streptococcal pneumoniae for more than 35 CT in number, which was considered as negative in routine diagnosis. And from the all cultured bacteria, we have one discordance about antibiotic resistance analysis, which was detected as resistant in silico, but the routine procedure find this bacterium is completely susceptible for all antibiotics used in this assay. And based on genomic analysis, additional information were added was added about the non-cultured bacteria in this case. And from the total of 22 non-cultured bacteria, 18 were remained susceptible, and 4 additional bacteria were detected as resistant for some antibiotics according to the in silico prediction of antibiotic resistance encoding genes. Total of 14 bacteria genotypes were detected in this series based on in silico analysis, including in majority Haemophilus influenzae B serotype and Neisseria meningitidis B serotype and Streptococcus pneumoniae 11I and 3I genotype. And all viruses detected in this series were for wild type genotypes. So to conclude about this work, using our procedure, we offered the possibility to detect in real time the pathogen genome from the first minute of the sequencing directly from the cerebrospinal fluid sample in case of central nervous system infections. And the using of the metagenomic without prior amplification and without specific target, we can document and we can detect infections non-routinely documented, and cases of unknown etiologies could be possible to document them. And the detection of the pathogens non-routinely diagnosed at the point of care laboratory is a new opportunity, could be used by could be available by using of total sequencing of the extracted DNA by real-time metagenomics, and this gives us the possibility to implement one-shot protocol for the detection, genotyping, and antibiotic susceptibility prediction of the microbe directly from the cerebrospinal fluid sample in limited time at the point of care laboratory, which could help the patient management and the prescription of the inadequate treatment in limited time to go speed in the management of the patient. And now we're working to replace progressively real-time PCRs by real-time metagenomics in specific situations to help to document meningitis of unknown etiology at the point of care laboratory and the first step of the emergency diagnosis. And in case of negative results in both situation, routine and metagenomics, we added supplementary procedure to investigate unclassified data or junk DNA to detect all microbial signatures of ancient infection in peripheral blood circulation and in and the rest of pathogen genome in cerebrospinal fluid sample after puncture, lumbar puncture in case of meningitis or meningoencephalitis. There is some interesting paper published in this topic by our team. And finally, I have to thank my team leaders and my head of laboratories. And I have to thank all persons contributed to this work and helped me to develop their strategies. And I have to thank you for your attention. Thank you.
Thank you, Dr. Mosley. That was a great presentation.
Thank you. I'm waiting for your questions.
Yes. Does anyone have any queries? I hope there are no queries.
Thank you.
Thank you, Dr. Mosley.
Thank you.
Thank you, Dr. Amrita, for your wonderful presentation.
Now let's move on to the next presentation by Dr. Evete Banulos Cabrera, Medicortex Finland PLC, Finland. Title of the presentation is Development of a Diagnostic Kit to Determine MTBI Using Patient's Urine. Dr. Evete, are you ready with your presentation? I can't hear you.
Can you hear me now?
Yeah, I can hear you now. Now I'm making you the presenter. Please click
Thank you.
on your screen. Yes, now I can see your presentation.
Yes.
You can start your presentation now.
Okay. Good afternoon, everybody. I am Yvette Bañuelos Cabrera, a senior researcher from Medicortex Finland OI, a company that is trying to develop of a diagnostic test to determine mild TBI using the patient's urine. Traumatic brain injury occurs after a hit to the head or to a sudden movement to the head. It can be caused, for example, due to falls, vehicular accidents, contact sports, and blasts. It causes immediate physical damage to the brain tissue. However, it also exposes the healthy part of the brain to metal ions, free radicals, and inflammation. This is called also secondary brain injury. And this set of events sets off a chemical reaction that damages surrounding healthy tissue. The leading causes of TBI, as I mentioned before, are falls with a 48%, followed by being struck by or against an object, and there are other or unknown causes, for example, blasts and explosions in military personnel, firearms, or medical procedures. Then motor vehicles accidents, it counts for 13%, and then TBI is a global problem. Every year there are new cases, and around 69 million of TBI cases are reported globally. US is the one leading the list, followed by Europe, Australia, and Canada. However, this is the countries where we have statistics. We don't know what's going on in a lot of countries or third developed countries, where for sure we have more cases. And approximately 90% of TBA cases in the general population, also in the military, are mild. And this is a risky condition, but is difficult to detect. So the need is we need accurate and rapid detection of head injuries. But to develop diagnostic tests for determine mild TBI, we first need to find molecules or biomarkers that are related with a brain injury. Here at Medicortex, we are working with glycans. Glycans that are also called polysaccharides are carbohydrate-based polymers made by all living organisms. Glycans are essential biomolecules serving structure, energy, storage, and system regulatory purposes. In this picture, I show you examples of glycan types. We have N-glycans or O-glycans, and these here are the common carbohydrates in mammalian glycans. In mammalians, galactose, sialic acid, fucose are part of these glycans. In Medicortex, we developed a preclinical study in a model of mild TBI in rats, and then by doing mass spectrometry, we found that there are multiple glycans increased in rats with mild traumatic brain injury. The next thing that we did here was perform a first clinical trial using urine, saliva, or blood of patients with suspected TBI and compare the results with healthy controls to know if these glycans are also increased in these patients with suspected TBI. Here, then, we obtain that effectively we have an increase in glycans in urine of patients with suspected TBI, in saliva too, and in blood, we are still developing the test. Then we perform a second clinical trial using patients with suspected mild TBI, patients with orthopedic injury and healthy injury. I'm hearing like sorry, but I'm hearing like a echo that okay, now it's okay. So we use patients with orthopedic injury and healthy controls, let's say, as controls, so we can determine if the glycans are specific with mild traumatic brain injury and not due to a fracture or another orthopedic injury. And we found also like an increase in these glycans. And then we developed a third clinical trial with samples obtained from children with suspected mild TBI and healthy control. Here is an example of the results that we got by mass spectrometry, where we evaluated the relative abundance of the glycans. And here are possible structures in TBI, blue, orthopedic, orange, and healthy, green. And we found that there are glycans increased specifically in TBI patients. By doing a more deep statistical analysis, we found 3 glycans that are just present in patients with mild traumatic brain injury when we compare with orthopedic or control patients. So Medicortex proprietary biomarker is a glycan. What we can do, or what can we do with this data? Well, what we want to develop is a lateral flow test kit to diagnose mild TBI using the patient's urine. So all of you know this kind of test because during the past years we were been doing tests for COVID. So these tests are quite similar to that, where we put a sample of urine in the test, we let it run, and then if we have a negative case or not mild TBI, one line will appear in the test. However, if we present or have a high probability or having mild traumatic brain injury, two-line tests will appear. But before developing this assay, we first need to find binders for the glycan biomarker that can detect it. So we started doing enzyme-linked lectin assay. Lectins are the natural binders for glycans. They are found mainly in plants. And we started developing this assay because it's more sensitive, so we could detect which lectins are the best ones to use as detectors. So we have 3 different configurations that I'm not going to explain in deeply. We have direct, hybrid, where we can use an antibody or another binder molecule and lectin, and then we have the sandwich test. First, we develop a direct assay using urine. We spike the urines with our bioglycan, and we observed that one of the lectins was able to bind to the bioglycan. And at higher concentrations of bioglycans, we could see an increase in signal. And also when we evaluate signal to background, we observe this binding, like the binding, like if it is higher than 1, indicates binding between our lectin and the bioglycan. And this binding is concentration dependent. Since our molecule is a small one, the glycan also, if we want to make this test more sensitive, we had to develop another kind of assay. It is competitive assay. In this assay, when we have a higher concentration of our glycan, we could observe a signal reduction as glycan concentration increases because they are competing with for the binding positions, as can show you here. And here in our competitive assay, we observe that when we are using higher concentration of our lectin and higher concentration of our glycan, the signal is decreasing. So this indicates to us that our lectin is able to detect our biomarker. And when we have a competitive assay, the detection might be better. We are still developing this part. But I can tell you that these results is really, really good because we were able to set up the first competitive assay to detect our glycan found in urine of patients with mild TBI. Now, the second step that we are developing is to perform the lateral flow test kit. We need to evaluate different membranes and different conditions to get it ready. But so far, we have found that using a nitrocellulose strip and using a colloidal gold label lectin, we were able to detect the glycans present in the urine of mild TBA patients using this nitrocellulose strip when we compare with healthy control. So, as conclusions, Medicortex has developed the first competitive assay using lectins capable of detecting the glycan. In the lateral flow strip, we could also detect the glycan when using golden label lectin. This is our team. We are working on this project together. And this is the contact of myself and also of the company if you have or you need more information about it. Thank you very much. If you have any questions, let me know.
Does anyone have any queries? That's a great presentation, Dr. Iwati. Thank you for your presentation.
Thank you.
Dr. Felice, can you give a presentation now?
Yes, I'm very pleased to take part at this conference on addiction, and I will present my speech about generalized epilepsy. One moment, I must.
Yes.
How do I manage this?
I'm making you the presenter.
So you must make me the speaker of
Yes.
this.
Yes. I'm making you the presenter.
One moment. Yes, it's okay. Um, doesn't function. It does not function. What's the problem?
You need to present your screen.
Yes, one moment. It doesn't work. It doesn't work. One moment.
Yes.
Yeah. Yeah. Okay. Okay. It doesn't work. What doesn't it work? doesn't, one moment.
Yes. Are you using an Apple device?
No, it's just a PowerPoint presentation.
No. Actually, I'm asking whether you are using a MacBook or Apple laptop.
I don't have an Apple laptop. I have a Microsoft laptop.
Okay. Then you should have accepted the icon I have sent you. I have made you the presenter now.
One moment.
You need
It doesn't work. It doesn't work. It does not work. It does not work. What is the problem? I don't know. It doesn't work. It
okay,
doesn't
then
work.
can you send your presentation to Veronica?
To whom? To Miss Lepisto. One moment. One
Yes,
moment.
yes.
One moment. Yes. Okay. One moment.
Okay.
Hmm. So I've just sent the presentation to Mrs. Lepisto. Okay.
Yes, kindly send there. I can share your PPT on behalf of you.
Yes. Okay. Tschüss, na. Yeah. So does not work. Does not work till now. Does not work. I don't know what to do.
Okay, fine. Then you can you once exit the meeting and then log in again? I can make you the presenter again.
One moment. One moment.
Dr. Felice, can you hear me?
Yes, I can hear you.
Okay, then now I'm going to make you the presenter. Please click on
Yeah.
the button you can see on the screen. Now,
Yeah.
have you received any pop-up?
No. Anything? One moment.
Okay. Yes, yes. Now your screen is visible to me. You can start your presentation.
I don't see it. I just see nothing. One moment. I see nothing. Oh,
Can you open your PPT?
oh. How should I do it? I just don't I see nothing at all. I see nothing at all. Nothing at all. There's nothing. Nothing
Yeah,
comes.
yeah. Yes, I can see your screen now. You need to open your PPT now. Yes,
Like this.
yes,
You
yes.
see it
You
now.
can
You see it
start your
now.
present. I can, yes, I can see your screen now. You can start your presentation.
Sorry for the difficulties in opening my presentation. I'm
It's
currently
okay,
working
Dr. Felix.
at the
Yes.
Grown Health Academy in Weimar in Germany in the formation of general and assistant nurses and I'm doing the scientific work at the Institute of Neurosciences of Castilla and León in Salamanca in Spain in collaboration with Rafael Cobeñas. Just so. In generalized epilepsy, alteration of classical neurotransmitters, acetylcholine, dopamine, gamma-aminobutyric acid, GABA, glutamate, noradrenaline, serotonin, and neuropeptides, neuropeptide Y, ghrelin, dynorphin, the hypothalamus, thalamus, hippocampus, and cerebral cortex are presented. In generalized epilepsy, a neurotransmitter imbalance between hyperactivity of D2 dopaminergic and hyperactivity of 5-HT2A serotonergic neurons occurs in the hippocampus. Besides presynaptic inhibitory GABAergic neurons with hyperactivity via GABA-A receptors and excitotoxic glutamatergic neurons with hyperactivity via NMDA receptors are involved in the neural network. In healthy subjects, the neural network shows a neurotransmitter balance. Considering the antiepileptic effect of agonists or antagonists of the mentioned neuroactive substances, novel antiepileptic drugs such as brivaracetam and perampanil are discussed in this oral presentation. The mechanism of action of these new drugs are described according to the neural network. Alteration of classical neurotransmitters and neuropeptides in generalized epilepsy. Acetylcholine. In generalized epilepsy, acetylcholine via muscarinic and nicotinic receptors is involved in ectogenesis. One muscarinic cholinergic receptor agonist exerts a proconvulsant effect. In an animal model of generalized epilepsy, it has been reported that one muscarinic cholinergic receptor antagonist and donepezil, a reversible cholinesterase inhibitor, have an antiepileptic effect. In animal experiments, donepezil also shows proconvulsant properties. In the hippocampus, alpha-7 nicotinic cholinergic neurons activate GABAergic neurons, and alpha-4 beta-2 nicotinic cholinergic neurons activate the 2 dopaminergic neurons. In children with idiopathic generalized epilepsy and in healthy subjects, polymorphisms of the chRNA4 and chRNAb2 genes have been studied. In the group with idiopathic generalized epilepsy, the T allele frequency of the chRNA4 gene was significantly different. This risk gene was associated with an alteration of the nicotinic receptor. Dopamine. In generalized epilepsy, dopamine, which performs the effect at D1, D2, D3, D4, and D5 receptors, plays an important role in ectogenesis. In the hippocampus, D2 dopaminergic neurons with a high activity exert a strong postsynaptic potential upon glutamatergic neurons, which apply a strong presynaptic inhibition upon 5-HT2A serotonergic neurons via NMDA receptors. Gamma-aminobutyric acid GABA, which applies a presynaptic inhibitory function via GABA-A, GABA-B, and GABA-C receptors, exerts an important function in the control of epileptic foci. In the hippocampus, GABAergic neurons can also contain somatostatin and neuropeptide Y. After an epileptic seizure, GABAergic neurons suffer a neuroanatomical reorganization, although they form less effective neural networks. In status epilepticus, GABA-A agonists lose their antiepileptic effect as a consequence of receptor trafficking. In the status, NMDA receptor antagonists show a higher efficacy because GABA-A receptors move from synaptic to extrasynaptic sites, and NMDA the other way around from extrasynaptic to synaptic sites. Question should be answered: which is the role of the metabotropic G protein coupled GABA-B receptors in the control of the hippocampal hyperexcitability? In the mouse model of a hippocampal kindling GS39,783, a positive allosteric GABA-B receptor modulator, and CGP 55,845, the selective GABA-B receptor antagonists, have been tested to know the involvement of these substances on the improvement of hippocampal EEG discharges. Neither baclofen, a GABA-B agonist, nor GS39,783 reduced epileptic potential. However, the combination of baclofen and GS39,783 abolished field potential. It is now that GABA-B agonists perform an antiepileptic effect by inhibiting glutamatergic synapses. Glutamate. Glutamate performs a postsynaptic excitatory potential. It means an excitotoxic potential upon neurotropic and metabotropic receptors and partly a presynaptic inhibitory effect. An augmented glutamate release could enhance ectogenesis. The neurotransmitter imbalance occurring between the hyperactive presynaptic inhibitory GABAergic neurons and between the hypoactive and the excitotoxic glutamatergic neurons could be due to traumatic brain injuries, brain insults, and/or status epilepticus. Metabotropic glutamatergic neurons influence echogenesis. In preclinical studies, it had been reported that both agonists of the metabotropic glutamatergic receptor 2 and 3 and antagonists of subtype 5 of metabotropic glutamatergic receptors exert anti-epileptic effects. Perampanel and AMPA receptor antagonist has been approved as an adjunctive treatment for the treatment of focal and generalized epilepsies. The medium dose of perampanel was 6 mg per day. When it is co-administered with other anti-epileptic drugs, such as enzyme-inducing drugs, enzymes that induce a cytochrome-mediated metabolism, such as carbamazepine or oxcarbazepine, topiramate, and phenytoin, the serum concentration of perampanel decreased. Serotonin. Preclinical models of epilepsy, it means in animal models of audiogenic epilepsy, genetically epilepsy-prone rats, and DBA2 mice, it has been reported that the mostly postsynaptic excitatory neurotransmitter serotonin exerts modulating effects in ectogenesis. Serotonin agonists exert anti-epileptic effects, whereas the blockade of specific serotonergic receptors, for example, the 5-HT2C receptor, has proconvulsant effects. Dynorphin. In animal models of epilepsy, animals missing the precursor of dynorphin showed an increased neuron loss in the hippocampus after injection of kainic acid into this brain area. In these experiments, kappa-opioid receptor agonists showed anti-epileptic effects. Galanin. Galanin is a neuropeptide which applies its effect via galanin 1, galanin 2, and galanin 3 receptors. Animals on which galanin hyperactivity was reported showed proneness to seizures. There is a neuronal interaction between hypothalamic galanin neurons and hippocampal serotonergic neurons. Question should be answered whether galanin 1 or galanin 2 receptor agonists exert an anti-epileptic effect by enhancing the hippocampal serotonergic neurotransmission. Neuropeptide Y. Neurons containing neuropeptide Y located in the dentate gyrus influence ectogenesis by inhibiting glutamate release. These neurons inhibit via NPY1 receptors hippocampal GABAergic neurons and glutamatergic neurons via NPY2 receptors. In experimental animals, NPY2 agonists exert the strongest anti-epileptic effect. How to derive neural networks in generalized epilepsy. In generalized epilepsy, the first hippocampal neural network was described in 2009. Dopamine and glutamate hyperactivity, as well as serotonin and GABA hyperactivity, can enhance ectogenesis. According to these neurotransmitter alterations, a neural network was published as follows. The two dopaminergic neurons with a high activity activate glutamatergic neurons, which perform a strong presynaptic inhibitory effect via NMDA receptors upon 5-HT2C serotonergic neurons. Latin neurons weakly activate GABAergic neurons, which presynaptically inhibit the two dopaminergic neurons. Withdrawal or reduction of the GABAergic inhibition upon the two dopaminergic neurons could enhance ectogenesis and induce epileptic seizures. Glutamatergic neurons also exert an excitotoxic effect upon the two dopaminergic neurons, enhancing ectogenesis. The principle of neurotransmitter balance and imbalance. In the hippocampal neural network, a neurotransmitter balance occurs when the involved neurotransmitters have equivalent concentration and potentials. For example, in the case that GABA levels and potentials are decreased for a short period of time, GABAergic neurons in the SOA presynaptically inhibit the two dopaminergic neurons. Hence, the two dopaminergic neurons exert an increased potential and strongly activate glutamatergic neurons. Latin neurons most strongly presynaptically inhibit serotonergic neurons. Serotonergic neurons weakly activate GABAergic neurons. In the case that the reduced activity of GABAergic neurons increases to normal values, the neurotransmitter imbalance is re-established. When the reduction of the presynaptic GABAergic inhibition is permanent, a neurotransmitter imbalance occurs and ectogenesis is enhanced. In this sense, glutamate excitotoxicity, dopamine hyperactivity, and serotonin hyperactivity could contribute to ectogenesis and induce epileptic seizures. This oral presentation is based on the following publication, Neural Networks in Generalized Epilepsy and Novel Anti-Epileptic Drugs, published in 2019, the journal Current Pharmaceutical Design. Neural networks in brain areas involved in generalized epilepsy. In generalized epilepsy, updated neural networks in the hippocampus hypothalamus, thalamus, and cerebral cortex are mentioned in this section. These networks have been adapted from previous reviews. This is a neural network on the right-hand side and the description on the left-hand side. Indicated are the brain regions, the cortex, the dentate gyrus, the thalamus, the hypothalamus, and the hippocampus. The circles symbolize the pericardians with the neurotransmitters glutamate, dopamine, acetylcholine, GABA, serotonin, adenosine, and the neuropeptides, neuropeptide Y and galanin. Lines symbolize the axons, and the plus mark symbolizes the postsynaptic excitatory potential, and the minus mark symbolizes the presynaptic inhibitory potential. The two dopaminergic neurons apply a strong postsynaptic excitatory potential upon glutamatergic neurons, which strongly presynaptically inhibit 5-HT2A serotonergic neurons via NMDA receptors. Glutamatergic neurons perform as well an excitotoxic effect via NMDA, KNET, and AMPA receptors upon the two dopaminergic neurons and can enhance ectogenesis. 5-HT2A serotonergic neurons with a low activity activate GABAergic neurons, which exert via GABA-A receptors a weak presynaptic inhibitory potential upon the two dopaminergic neurons. Withdrawal or reduction of the GABA-A GABAergic inhibition of the two dopaminergic neurons can cause epileptic seizures. Hippocampal GABAergic neurons weakly inhibit thalamic glutamatergic neurons, which activate other cortical glutamatergic neurons. Latin neurons can activate hippocampal, the two dopaminergic neurons. 5-HT2A serotonergic neurons perform weak postsynaptic excitatory potential upon GABAergic neurons, which weakly presynaptically inhibit A2A adenosine neurons via GABA-A receptors. A2A adenosine neurons with a high activity strongly activate glutamatergic neurons, which apply via subtype 5 of metabotropic glutamatergic receptors a strong presynaptic inhibition upon 5-HT2A serotonergic neurons. Therefore, A2A adenosine neurons and antagonists of subtype 5 of metabotropic glutamatergic receptors exert anti-epileptic effects. Neurons with galanin located in the hypothalamus activate hippocampal 5-HT2A serotonergic neurons. Other serotonergic neurons activate hippocampal 5-HT2A serotonergic neurons. Alpha-4 beta-2 nicotinicholinergic neurons activate the two dopaminergic neurons, and alpha-7 nicotinicholinergic neurons activate GABAergic neurons located in the hippocampus. Other GABAergic neurons via GABA-B receptors exert a presynaptic inhibition upon hippocampal glutamatergic neurons. Preclinical studies, it has been demonstrated that positive allosteric modulators of GABA-B receptors exert an anti-epileptic effect. Neurons containing neuropeptide Y located in dentate gyrus presynaptically inhibit GABAergic neurons via NPY1 receptors and glutamatergic neurons via NPY2 receptors. Novel antiepileptic drugs. In this section, the novel antiepileptic drugs GS39,783, a positive allosteric modulator at the GABA-B receptors, parampanil and AMPA receptor antagonist, and brivaracetam are mentioned due to the importance of the different mechanisms of action implicated in generalized epilepsy. Positive allosteric modulator at the GABA-B receptors. Metabotropic GABA-B neurons influence ectogenesis by inhibiting glutamate synapses. In an animal model of the hippocampal kindling, the positive allosteric modulator of the GABA-B receptor GS39,783 in combination with baclofen, GABA-B receptor agonist, decreased epileptic potentials. Clinical studies, the anti-epileptic effect of these new drugs should be investigated. Perampanil. Perampanil, an AMPA receptor antagonist, has been approved as an adjunctive treatment for focal and generalized epilepsies. The safety and efficacy of perampanil has been examined in 256 patients. Perampanil was administered as an adjunctive treatment for partial onset seizures and primary generalized tonic-clonic seizures. In most cases, patients were treated with 2 additional anti-epileptic drugs. The mean perampanil dosage was 7.06 milligrams or 8.26 milligrams at 6 and 12 months respectively. The responder rate was 39.5% or 35.9% at both follow-up points respectively. Adverse effects such as somnolence, dizziness, and irritability were experienced in 35.5% of patients. The authors reported no difference when combining perampanil with enzyme-inducing or not inducing anti-epileptic drugs. Brivaracetam is a new antiepileptic drug approved for the add-on therapy of adult focal seizures. It has a 15 to 30-fold higher affinity for the synaptic vesicle to A than levetiracetam. It has a high solubility and a rapid brain penetration. In experimental animals, it showed a strong antiepileptic effect. In a phase 3 study, it showed good tolerability and a favorable pharmacokinetic. Brivaracetam also showed a good efficacy in secondarily generalized tonic-clonic seizures, and the long-term administration of these new antiepileptic drugs was well tolerated. In a large cohort, it has still to be examined whether brivaracetam induces favorable effects. It means no psychotic inducing psychiatric adverse effect. Conclusion. Based on previous reviews about the neural networks involved in generalized epilepsy and according to the mechanism of action of conventional and new antiepileptic drugs, we have updated these neural networks. In generalized epilepsy, we also updated the alteration of neurotransmitters and neuropeptides that influence ectogenesis. They are located in the hippocampus, hypothalamus, thalamus, and cerebral cortex. GABAergic neurons via GABA-B receptors inhibit presynaptic hippocampal glutamatergic neurons. The principle of neurotransmitter balance and imbalance are also described. The main four neurotransmitters, dopamine, serotonin, GABA, and glutamate, have a reciprocal neurotransmitter balance with each other. These neurotransmitters are involved in a neural circuit that maintains such balance. In the case that neurotransmitter alteration, for example, dopamine hyperactivity, serotonin hyperactivity, deficiency of GABAergic presynaptic inhibition, or glutamate excitotoxicity do not occur for a short time period, but they are permanent. Neurotransmitter imbalance appears, enhancing ectogenesis and inducing epileptic seizures. The importance of modulating neuropeptides such as galanin and neuropeptide Y is also considered. In experimental animal models, the GABA-B receptor agonist GS39,783 inhibited epileptogenic glutamatergic neurons and exerted an antiepileptic effect. The action of this agonist should be investigated in clinical studies. In pioneer clinical studies, the AMPA receptor antagonist perampanil has been safe and efficient for the treatment of partial onset seizures and primary generalized tonic-clonic seizures. Brivaracetam had a good clinical safety and efficacy in the add-on treatment of adult focal seizures and secondarily generalized tonic-clonic seizures. Thank you for your attention by Felix Martin Werner and Rafael Cobeñas.
Thank you, Dr. Felix. That was a great presentation. Does anyone have any queries? I hope there are no queries. Okay, let's have a lunch break now. And again, all of us join us by 1:30 p.m. Thank you.
Okay.
This conference will now be recorded. This conference will now be recorded.
Hi everyone, welcome back to the afternoon session. Dr. George, is it possible for you to present now?
Hi.
Hi, is it possible for you to present now?
Yeah. Yeah.
Okay, thank you. Now I'll make you the presenter.
Okay.
I gave you the access.
Okay. Can you see my screen?
No, I can't see your screen. I can see you, but I can't see your screen.
Okay.
Yes, now I can see your screen.
Okay. So you can see my screen now, right?
Yes, I can see your screen. Yes, I can see your presentation.
Okay. So can I move on with my presentation?
Yes, you can start your presentation.
Okay.
Thank you.
All right. So good afternoon, conference chairperson and everyone. It's a great pleasure to be on this platform. My name is George Ofori Ochre, an administrative assistant of Prestige Leasing Limited in Ghana. I'm not a neurologist, but a historian. I have a bachelor degree in history and geography. Now, I developed interest in neurology when I grew up to see my sister suffering from brain disorder. And looking at the family history, she was the only one. It was odd. Now, with this, it has given me this great pleasure to speak on the topic advancement in neurology and brain disorders. And I'll be looking at the insights, diagnosis, and therapies. So this is a picture of the human brain, a picture of the human brain. Okay, so let me move on with my presentation. Okay, so let's look at the insights. Now, one may ask, what is neurology? Neurology is a medical specialty that deals with diagnosis and treatment of disorders of the nervous system, which includes the brain, spinal cord, and nerves. Neurological and brain disorders are a wide range of conditions that affect the brain and can cause variety of symptoms, including cognitive impairment, motor dysfunction, and sensory disturbances. Neurological and brain disorders are a major burden on the society, affecting millions of people worldwide. A new report from the World Health Organization shows that neurological disorders, ranging from epilepsy to Alzheimer's diseases, from stroke to headache, affect up to 1 billion people worldwide. Rita Levi-Montalcini, winner of the Nobel Prize in Medicine, commented, "The burden of neurological disorders is reaching a significant proportion in countries with growing percentage of the population over 65 years. Some common brain disorders are Alzheimer's diseases, Parkinson's diseases, stroke, and others. According to the World Health Organization in the year 2007, the Africans, the Americans, the Eastern Mediterranean, Europeans, Southeast Asia, and the Western Pacific are 6 continents or regions in the world that suffers from neurology and brain disorders. Can you hear me, madam? Can you hear me, madam?
Yes.
Okay. Now, according to Murray and others, 2012, in the year 2010, neurological disorders constituted 5.5% of year lived with disabilities. This research paper explores recent advances in the understanding, diagnosis, and treatment of neurological and brain disorders. The study focuses on Alzheimer's and Parkinson's diseases. Now, one may ask, what is an Alzheimer and Parkinson's diseases? Alzheimer diseases was discovered by Dr. Elias Alzheimer and described it in the year 1906. It is a neurodegenerative disorder that causes progressive memory loss and cognitive decline. It is caused by the abnormal buildup of proteins in and around the brain cells, which is amyloid and tau deposits. The amyloid deposit forms plaques around the brain cells, and the tau deposit forms tangles within the brain cells. These proteins damages and kills the nerves cells, leading to a loss of memory and cognitive functions. A new study published in Nature Science found that a protein called amyloid beta, which is known to build up in the brains of people with Alzheimer's diseases, can also damage the blood vessels in the brain. And the damage can lead to inflammation and cell death, which are thought to be early steps in the development of Alzheimer's diseases. Now, the blood vessels which is damaged are known to supply oxygenated blood to the brain. And when these vessels are damaged, it affects the constant flow of blood to the brain, which causes loss of neurological functions, causing neurological disorders like stroke and others. So when these blood vessels are damaged in the brain, it means the functions of it to carry oxygenated blood to the brain pauses, which causes neurological disorders. So I have a picture depicting the father of Alzheimer's. That is how historians talk. Anybody that describes something, that brings about something, is called a father of what that person brought it up. So we have an image of Dr. Elias Alzheimer's, which I know to be the father of Alzheimer's diseases, since he brought it up in the year 1906. So let's look at Parkinson's disease on the other hand, which was first described by Dr. James Parkinson in the year 1817. It is also a neurodegenerative disorder that causes tremors, stiffness, and difficulty with movement. It is caused by an influenza virus and loss of nerve cells in the part of the brain called the substantia nigra, which is a midbrain dopaminergic nucleus, which has a crucial role in modulating motor movement and reward functions as part of the basal ganglia circuitry. The nerve cells are responsible for producing a chemical called dopamine, which is a neurotransmitter which is crucial for motor and movement control, cognitive executive functions, and emotional limbic activities. Now, this limbic activity, then we are talking about the limbic system, which is also known as the is it the limbic, which plays a critical role in emotions, memories, and behavior. And I think Dr. Felix Martins Werner made mention of some of the part of the limbic systems when he was talking about the treatment of epilepsy. Yeah. So both Alzheimer's and Parkinson's disease has no cure, but there are treatments that can help manage the symptoms. These treatments include medications, lifestyle changes, surgery, and supportive care for patients. So I also have a picture depicting the father of Parkinson's. That is Dr. James Parkinson's. Yeah. I don't know if it's clear over there. So let's continue. Okay, so we move on with the diagnosis. So diagnostic tests and procedures are vital tools that help physicians confirm or rule out a neurological disorder such as Alzheimer's and Parkinson's diseases, which my focus of this presentation is on. A century ago, the only way to make a definite diagnosis for many neurological disorders was to perform an autopsy after someone has died. How can we diagnose somebody who is dead? To know what was wrong, to know the neurological disorder which caused that. But we thank God today, our neurologists have new instruments and techniques. Our scientists have new instruments and techniques that allow them to assess the living brain and monitor nervous system activities as it occurs. Doctors now have powerful and accurate tools that better the diagnosing of neurological disease and to test how well the particular therapy will be working. So I have a picture also here depicting a doctor diagnosing an Alzheimer's patient. And look at how lively is this. I don't know the kind of communication going on, but it's a live picture which is showing how a doctor is diagnosing an Alzheimer's patient. Yeah. Okay. Perhaps the most significant changes during the past 10 years have occurred in genetic testing and diagnostic imaging. Much has been learned from sequencing the human genome, that is the complete set of a person's genes, and developing new technologies that detect genetic mutations. Improved imaging techniques provide high-resolution images that allow physicians to view the structure of the brain. Specialized imaging methods can visualize changes in the brain activities or the amount of particular brain chemicals. Brain scans include several types of imaging techniques used to diagnose tumors, blood vessels malfunctions, strokes, injuries, abnormal brain development, and hemorrhage in the brain. Brain scans like computer tomograph, magnetic resonance imaging, positron emission tomographs, and single proton emission scans support an Alzheimer's diagnosis or rule out the possible causes. Doctors usually diagnose Parkinson's diseases by taking a person's medical history and performing a neurological examination. So I have a picture depicting a patient going through a brain scan. Yeah, so I think that is how most of the brain scans are done. So there is a picture depicting a patient going through a brain scan. Yeah. So we are going to look at the various types of the brain scans, and I'll be talking about three. So the first one is computed tomograph, which uses X-ray to produce two-dimensional images of organs, bones, and tissues. A computer tomograph scan can aid in proper diagnosis by showing the area of the brain that is affected. It can be used to quickly detect hemorrhage in the brain and also determine if someone who has had stroke can safely receive intravenous treatment to dissolve clots. A contrast dye may be injected into the bloodstream to highlight the different tissues in the brain. So that is how the computed tomograph scan works. So I have an image of a CT, a computed tomograph scan for an 88 years old Alzheimer's patient. Yeah, sorry, I have a watermark in the picture. Yeah, so this the results after an 88 years old Alzheimer's patient was scanned using the computed tomograph scan. So let's move on to the magnetic resonance imaging, which also uses computer-generated radio waves and a powerful magnetic field to produce detailed image of body tissues. Using different sequence of magnetic pulses, magnetic resonance imaging can show anatomical images of the brain or spinal cord. It measures blood flows or reveals deposits of minerals such as iron. The magnetic resonance imaging is used to diagnose stroke, traumatic brain injury, brain and spinal cord tumors, inflammations, infections, vascular irregularities, brain damage associated with epilepsy. So that is brain damage associated with epilepsy, abnormal developed brain regions, and some neurodegenerative disorders. So I also have a picture of a magnetic resonance imaging scan showing after a test. So we have a no dementia, a very mild dementia, and a mild dementia. So that was the result after a magnetic resonance imaging scan was used to diagnose a patient with a neuro or with a brain disorder. Sure. So let's look at the positron emission tomograph. So the positron emission tomograph scan provide 2 and 3-dimensional pictures of the brain activity by measuring radioactive isotopes that are injected into the bloodstream. PET scans of the brain are used to detect or highlight tumors and diseases diseased tissues. They show blood flows and measure cellular or tissue metabolisms. The positron emission tomographs scan can be used to evaluate people who have epilepsy or certain memory disorders and to show brain changes following injury. It may be ordered as a follow-up to a computer tomograph or a magnetic resonance imaging scan to give the physician a greater understanding of the specific area of the brain that may be involved with problems. So I also have an amyloid PET scan. So there is a picture depicting an amyloid PET scan. Let's look at the therapies. So recent advances in neurology and brain disorders have led to a better understanding of the underlying mechanisms of these conditions. The field of neurology has seen the development of new therapies for brain disorders. These therapies include new drugs, surgical techniques, and gene therapy. Below are some new drugs developed for Alzheimer's diseases and Parkinson's diseases and other neurodegenerative diseases. So I also have an image here of patients undergoing a brain surgery. And brain surgery are some of the therapies to hold or to cure brain disorders. And it's lively. You can see the physicians working on patients with brain disorders, and they are using the brain surgery method to, to cure their brain diseases. So first of all, I would like to look at researchers at the University of Pennsylvania. So they developed a new way to treat Parkinson's diseases, and it is a new treatment called deep brain stimulation, which involves implanting electrodes in the brain that can send electrical signals to the brain to control movements. So it's a new treatment called deep brain stimulation, which involves implanting electrodes in the brain that can send electrical signals to the brain to control movement. And this is usually done for patients with Parkinson's diseases. Also, a new study published in the journal Science Translation Medicine found that a drug called levodopa can help neurons from damage in Parkinson's diseases. But this study also found out that it can also help the disease from progressing. So when patients with Parkinson's diseases take this drug called levodopa, it can help the neurons from damage. And that is not all. It also prevents the diseases from progressing. So this was done by, it was published in the journal Science Translation. So there is a picture also depicting a patient going through a deep brain stimulation. So in the picture, we can see an electrodes planted in the brain of a patient with Parkinson's. So a Parkinson patient. So these electrodes will help movement, will help like, so as I said earlier, I said it sends signals, electrical signals to the brain. So it will send electrical signals to the brain to aid in movement. To add up, researchers at the University of California, San Francisco, have developed a new way to diagnose Alzheimer's diseases in its early stage. And this new test is called amyloid PET. Amyloid PET can detect amyloid plaques in the brain, which is a hallmark of Alzheimer's diseases, allowing for earlier and more diagnosis. Finally, a study published in the journal Science found that a drug called GMV 3905 can help protect nerves from damage in a mouse model of Parkinson's diseases. So I also have a picture showing some drugs for Alzheimer's patients. I couldn't, describe the drugs as you can see. So it's a group of drugs, different drugs which are given to Alzheimer's patients to cure the disease. So I also have that of the drugs for Parkinson's diseases. Yeah. Okay, so let's look at the conclusion. The field of neurology is rapidly evolving, offering new hope for patients facing Alzheimer's and Parkinson's diseases and other brain disorders. With continued research and innovations, we can expect to see even greater advancements in our insights, diagnosis, and therapies of these complex conditions. According to a study published in the European Journal of Neurology, June 2005, the reason for the non-availability of treatment include inadequate health delivery systems, lack of prevalence of traditional beliefs and practices. So in order to reduce the impact of neurological diseases, innovative approaches involving strong partnership must, must be put in place, said Professor Johan Ali, president of the group of the World Federation of Neurology and member of the group that wrote the report. So I'm much interested in the part when he said, in order to reduce the impact of neurological disorders, innovative approaches involving strong partnership must be put in place. And in history, we call this interdisciplinary approach, where scholars from different disciplines will come together and find solution to this to so they will find a solution to a problem. So when a historian is recommended by a neurologist, what is the historian going to do to help solve this issue? He will be looking at the history of the brain disorders I'm talking about, which is the Alzheimer's and Parkinson's diseases. Let's look at the roots where these diseases started. When? So I think when this statement by Professor John Ali is taken into consideration, it can help us find a future solution to these neurological and brain disorders others are facing. Despite the challenges, there is hope that new treatments and new cure for Alzheimer's and Parkinson's will be found in the future. Research is ongoing, and scientists are making progress in understanding these diseases and developing new ways to treat them in order to improve the lives of millions of people affected by neurological and brain disorders. And this was stated by researchers at Umeå University, Sweden, in collaboration with researchers in Croatia and Lithuania in July 2021. Renew hope for novel treatments for Alzheimer's and Parkinson's diseases in the long run. So I also have a picture of a neurologist working together to find future solutions to neurological disorders. And this is what I was, talking about, supporting what Professor John Ali said. We should bring people together from different disciplines, should come together, then we should find a future solutions to neurology and brain disorder. I hope this presentation has been informative. Thank you for your time. Okay, thank you. So any question? Hello, madam.
Thank you,
Hello,
Mr. Job,
madam.
for your wonderful presentation. I think Dr. Santosh has a query.
Yeah.
Can you hear me?
Yes, Dr. Santosh.
Yes.
You can ask your query.
Yeah. I need to. I thank Mr. Offrey for making a good presentation. Your presentation, Mr. Offrey, is very informative. I just wanted to make one point. When you talked about this Parkinson disease and Alzheimer disease, where the memory loss, and also you talked about there are various therapy options are there. There are new innovations, and also you made a point that there is a now option of deep brain stimulation. The deep brain stimulation. Am I clear? You can listen me. So deep brain stimulation method, it can be very challenging when we want to treat the people. If you see their age, people those who are in the age group of maybe more than 60 or 70 or 80 years of age. So treating those type of people with this type of Alzheimer and Parkinson disease, it becomes very challenging. So and it also depends upon the person's overall health parameters, other health parameters, their blood pressure, their whether they have other their hemoglobin is within limits and other health parameters. So it becomes very difficult to apply it methods like deep brain stimulation for those people who are aged people or senior citizens, maybe who are 60 or 70 years of age. So how do you react to my point? I hope I was clear in my communication.
No, I didn't hear the question. Hold on.
Mr. Offrey, you could not understand. Shall I repeat?
Hold on.
You can listen to my voice.
We can listen
Yeah.
you, but I
So can
think
you come
Dr. George.
again?
Yes. You repeat your query, Dr. Santosh?
Yeah. I will speak little slow. My query is that in case of people, those people who are elderly people, maybe who are age group of 70 or 80 years of age. So for treating this type of people, this type of Alzheimer's disease, where there is a memory loss, with this technique, deep brain stimulation, which has been suggested by the presenter, it becomes very challenging because at this age, many medicines do not work with people. And it also, apart from age, it also depends on other health parameters of people. So this type of a deep brain stimulation method may not work. That's the point I wanted to make. If you see the age, after a particular age, it becomes very difficult to treat the people. Certain medicines do not work. It also depends upon a person's or he or her overall health parameters. So how do you react to this? When you have made a mention that we can use the method named deep brain stimulation. Am I correct? Deep brain stimulation method you have suggested in your presentation. We can use this method, but it's become very difficult for to treat those people who are elderly people who are above the age group of 60 or 70 or 80 years. So we cannot use this deep brain stimulation method for treatment of for treating this type of people who have other health complications. I were talking in
Hello?
terms of health complications, age, and um, other therapy options which are available with us.
Yeah, Dr. Santos,
Yes,
can you hear me? Yeah,
yeah, I can hear
I
you.
don't, yeah, I don't get your question clearly, but I think you are asking about deep brain stimulations.
Yeah, yes, brain stimulation, and also those treating those people who are senior citizens, who are elderly people, those who are above the age of 70 or 80 years. So how do we can treat this type of people with a deep brain stimulation method?
Okay, so you are asking how can we use brain deep brain
Stimulation,
stimulation,
yes,
okay, for people with old age.
yes,
Okay, all right. Okay, so if I understand you,
yeah,
uh, so I think I don't have enough information about that.
okay,
Yeah. I don't have, yeah, because I told you earlier, uh, I'm a historian, but
Oh, okay, okay.
I'm a historian and a
Uh,
geographer. So that is
okay,
what I specialize in. I have a bachelor of degree in history, but I have a sister who suffers from this brain disorders. So along the line, I switched just reading, always reading about it to help shape her life. So these are
okay,
some of the things I learned when anytime I read on brain disorders. So I came along this, then that was the explanation I got for deep brain stimulation. So I don't know with
stimulation
your
method.
question if you have any like a vivid answer to that.
Okay,
I'll be glad to receive it and write it down so that any time I go somewhere and I'm asked that question, I'll use Dr. Santos' answer for them.
yeah.
You get me?
Okay,
Aha, yeah. So
okay,
I'm ready to receive your answer concerning how people with deep brain
okay.
stimulations, yeah, and yeah, how we use it for people with old age.
Yeah, yes, yes. It's very important to understand the age group of the patients. So we have to see those who are senior citizens. I hope understand when I use the word senior citizen, mean those who are above the age of 70 or 80 years. For them,
Uh-huh.
treatment becomes very challenging. It's not so easy. Many medicines do not work. We need to understand
Okay.
there are other health parameters. Uh, so,
Okay.
treating a person who is of 40 years of age and treating a person who is of 70 years age, it makes a lot of difference. Okay, the age also matters a lot. That's what I wanted to make. I hope you agree with what I say. So,
Yes,
using this
please.
type of very sophisticated deep brain stimulation method
Um,
for people who are 70 years of age, it might be a little challenge. Anyway, thank you so much.
you're welcome, Dr. Santos. Thank you for your submission to. Yeah, thank you. Yeah. Is any other question?
Does anyone have any more queries? I
Okay, so
hope there are
if
no
there
queries,
is
Dr.
no,
George.
it's just please. Yeah. So,
Yes.
Madam Ima, I just want to use this opportunity to talk about. We have some special schools in my country, Ghana, who are, suffering enough from these brain disorders. My sister is one of them. So I took her to one of the special schools in Ghana. It was called the Jolu Specials. And later I transferred her to Nkranza Shalom Special Schools. And anytime I go there, what I see with my eye, they are suffering lack of even resources where these patients will live. It's a problem. So I always do a follow up. My sister is there. And through these readings, I've been able to shape her life. I don't use drug, but the lifestyles, don't do this, don't do that. When you see her, she's so special. Now she can do everything on her own. So I don't know if we have some supporting organization, they can turn to Ghana, then they can support our brothers and sisters suffering from these brain disorders. They are really suffering here. Thank you.
Yeah, you are right.
Thank you, Madam Emma.
Thank you, Mr. George. Thank you for your presentation as well.
All right. You're welcome,
Now,
Madam.
yes. Now let's move on to the presentation by Santosh Kumar Mishra, SNDT Women's University, India. Title of presentation is An Investigation into Alcohol Dependence, Alcoholism, and Sexual Disorders Among Adolescent Boys and Girls. Dr. Santosh, are you ready
Yeah,
with your
you can
presentation?
listen my voice. I hope you can listen my voice. So
Yes,
I
I can
just
hear you.
request you to share my presentation screen.
Yes, Yes, I'll share your
Yeah.
presentation.
Thank you so much. I'm just waiting for my presentation screen to come on my laptop. I hope you can find my PowerPoint presentation which I sent today morning to you. You want me to send it to you again? Yeah, right. Yeah, I can see. I can see my slides. I can see my slide.
Yes, Dr. Santosh, you can
Yeah,
start
I
your
can. Yeah,
presentation.
thank you. So shall I start my presentation?
Yes, you can start now.
Yeah. Okay. Thank you so much. Uh, good evening, according to my time at Mumbai in India. So good evening, according to from me. And to begin with, I extend my warm welcome and greetings to on behalf of the Republic of India and also on behalf of the SNDT Women's University, where I was working previously. I offer my good wishes and greetings to all the participants of this second International Conference of Addiction and Psychiatry, which is taking place today, November 22, 23 Monday by webinar mode. And my first slide tells about my institutional affiliation. So as you can see from the I can just having a look at my watch. I think I'm getting 25 minutes time. I'm just going to I will look at my watch so that I respect the time limit. And at the end of the presentation, I will have some time left out for questions or for any clarification if somebody wants to have about any aspect of my presentation. So to begin with, and within the given limited time, I will try to make my presentation as simple as possible, as informative, as interesting as possible. Uh, so my first slide talks about my institutional affiliation. As you can see from the first slide, right now I've retired from this SNDT Women's University. Now I'm working in the capacity of independent research and a scholar, and I retired on June 30, 2020 from this unit which was known as Population Education Resource Center. In short, we call it PERC, which stands for Population Education Resource Center. And this Population Education Resource Center is attached with this Department of Lifelong Learning and Extension. We call it DDLE, Department of Lifelong Learning Extension. And this Department of Lifelong Learning Extension was earlier known as the Department of Continuing and Adult Education Extension work. And because many researchers and educationists believe that learning is a lifelong process, so the university system and the University Grants Commission, which comes under the Ministry of Human Resource Development, Ministry of Human Resource Development of the Government of India, which is responsible for controlling the universities in India. So we realize that since learning is a lifelong process, so it is better we rename this department Department of Lifelong Learning and Extension. So this Department of Lifelong Extension was attached with the SNDT Women's University, which is located at a place named Churchgate. Churchgate is a suburb, of western suburb of Mumbai city, which is in Maharashtra state of Republic of India. So I'm working there, and now I have retired from this university. So in my present designation is independent research and scholar, and thereafter I have given my contact details, my email address, and my WhatsApp connected mobile number. Nowadays, in the age of social media, I do a lot of contact to the conference organizers through my WhatsApp connected mobile number for sending the papers for presentation. And at the end of the second slide, first slide, I have given my physical address. This is my residence address where I'm staying at Malad West, at Mumbai, in India. Next slide, please. Next slide is about, thank you so much for changing the slide for me. This is about myself. Very quickly, I should not take much of time. Again, next slide, please. Next slide, please. Slide 3. Slide number 3. Thank you so much. This slide tells very quickly about my qualifications, what is my profile, all the academic and research contributions I have made, and all the professional and other related experiences I have over the years when I was working with the university. So as I said in the previous slide that I have retired from the PERC, which stands for Population Education Resource Center, DLLE, which stands for Department of Lifelong Learning and Extension, and SNDT Women's University. It's a very long name. In India, we have a system of having very long names of universities, and some people also very long name. So this is the institution, Population Education Resource Center, Department of Lifelong Learning and Extension, SNDT Women's University, whereby I worked for over 32 years. I worked. I joined the university in August 1987 and I retired in June 2020. And this is the time, June 2020, I remember when the entire world was under lockdown, there were COVID restrictions. So I retired from the university, from this SNDT University in June 2020. And in terms of my academic qualifications, I acquired master's degree in economics. Thereafter, I underwent training in demography, and also I acquired PhD degree in the year 1999. And title of my PhD work was Role of Non-Governmental Organizations in Population Education Program in India. And I also acquired other qualifications like I did a diploma in hotel management, diploma in human resource development, certificate course in hospital healthcare management. And I should not speak much about that, but nevertheless, I would like to make 2 points at this juncture that if anybody of today's conference on today's conference and, today's second international conference on addiction and psychiatry. If anybody interested to know more about me, about my qualifications, my academic background, my experiences, my publications and experiences, I have several publications also. At this point, I can make at least 2 points that I have several publications to make read. I have authored books, I have authored book chapters, journal articles, and I have contributed to over 200 e-discussion debates, and also I am a editorial board member for around 93-94 journals. Until that, I have reviewed around 188 or 190 journal articles, and I've also served as a reviewer for papers which are presented at various international conferences for seminars for international conferences, and also I have served as a judge and evaluation panel member for various occasions. So, but if somebody interested to know more about me, you go to the Google on the browser. You just type my name, Dr. Santosh Kumar Misra, PERC, SNDT, Women's University, Mumbai, in India. So you get a lot of sites which tells about they have my several publications also. They have my biodata, and they detailed about my academic qualifications and other experiences outlined. And apart from that, at the end of slide at the end of slide 3, yes, I have quoted 3 websites, A, B, and C, you can see. So if any of the links, if you click A, B, and C, you will find details about my profile in my academic and professional qualification, my research experience, and all the professional contributions I have made over the years. So without wasting more time, allow me to go ahead. And next slide, please. So now straightway, slide 4 of my presentation. Now I'm referring to slide 4 of my presentation. Yeah, right. I can see that. Thank you so much for coordinating with me. And I also apologize, I could not share my screen from my side. There was some my error, computer system has developed some error. So today's presentation title is an investigation into alcohol dependence or alcoholism and sexual disorders among adolescent boys and girls. So this is the brief outline. So in my presentation, I will tell about the importance of my work, why my work is important, why I chose to uh, take up this study where I'm trying to research into the interlinkages between alcohol abuse or alcohol dependence, or we can use the word alcoholism, and sexual disorders among adolescent boys and girls, and why my work is important, what is what is rational, and what are his objectives, what are the research methodology, and what are the key findings of my work. And also I will tell very briefly about which are the sources which I have quoted for the purpose of reference for preparing my present research work. So in terms of brief outline of my presentation, to begin with, I will talk about introduction, including rationale, objectives, what are the objectives of my work, and also the what research methodology I have used in my work, and also major data analysis, including key findings, and some keywords used in my work. As per the standard research ethics in our abstract, we are or any journal article, we are expected to, as a researcher, we are expected to write the keywords which I've used, and also conclusions and references. So this is the brief outline of my presentation. So to begin with, let me tell you very quickly about why my work is important before I go to the next slide. My work is important because alcohol consumption has been in practice in many parts of the world, including in India, including some parts of Europe, including countries in African countries, European countries, Caribbean countries, Latin American countries, and alcohol abuse in various forms. It is available. It is already in practice, and it's not new. Alcohol consumption not new, but alcohol consumption, or I should say alcohol abuse, or alcohol dependence, like depending on a person becoming alcohol, it has several health consequences. Many people get used to get exposed to several health disorders because of alcohol consumption. So in my work, I mean, alcohol consumption or alcohol dependence may have a health implications, including reproductive and sexual health of boys and girls, both men and women, not only adolescent boys and girls. In my work, I am going to concentrate, I am going to talk more about how the alcoholism has impact or consequences for sexual disorders among adolescent boys and girls. So, but nevertheless, it has impact on people, on health of sexual health of people of all age group. Maybe of those who are of younger age group, those who are of 15 to age group of 15 to 30, or maybe 30 to or 15 to 50 years of age, or even people who are in the age group who are in the above 70 years or 80 years of age. But the impact differs from number one age group of the person, number one, boys and girl, and men and women, number one, and number two, other health parameters. But sexual health and sexual and reproductive health of both men and women, boys and girls, is impacted by alcohol dependence, and it has various aspects. But in the context of alcoholism, I must say that social media and also impact of television has impact on people uh, these social media and television and other digital platforms to some extent are responsible for people getting addicted to alcohol and people abusing alcohol and people depending on alcohol. So we as a researcher and we as a I, in my capacity researcher, we all as scholars and stakeholders in the health sector, I believe this is a conference on something to do with health. So we all are here. We all are here from representing different organizations working in different health sectors. So we all have our own role to play in ensuring that how alcohol dependence does not cause sexual disorder among adolescent boys and girls. Uh, so, so before I go ahead, I want to make a statement that there is a linkage. Yes, I agree that there is a linkage between alcohol dependence and alcoholism and sexual disorders. And before I go ahead, I must tell you that sexual disorder. I will tell you in the later slide how exactly I define the word alcohol dependence, alcoholism, and also how I define the sexual disorder. What exactly the scientific meaning of sexual disorder and sexual dysfunctions. It is also known as sexual disorder, sometimes is also known as sexual dysfunctions, and so these are two words used alternatively, both carry the same meaning. So in the next slide I will tell how exactly it is defined, but I must tell you that sexual disorders are impacted not only by alcohol itself, alcohol consumption itself. There are other parameters like health of a person, he or she, health of a person, other overall health parameters of people like their food habit, their socio-economic demographic profile, their family values, their social and cultural background, and also whether people have been people have been exposed to any violence sort of situation, or in case of girls, if they were ever they had any bad experiences of rape or sexual violence or any violence within the family or within the society they live in. It is applicable to both boys and girls. So these incidences like lifestyle disease, food is, and life. When I use the word lifestyle disease, I mean eating the right food at the right time. So always I tell people that there are key to parameters which are very key to having good health for now and in the long run. One is that eating the right food at the right time, eating and early to bed and early to rise makes a person healthy, wealthy, and wise. So these are some key factors. So now I go to the next presentation. So apart from alcohol abuse, there are other factors also. I don't want to talk much about all these aspects because it does not come within the purview of my work. But there are other factors like I told you, lifestyle disease, other critical illness and drug abuse, smoking, and other previous sexual health background and other personal exposure to sexual violence or sexual abuse or any violence within the family or conflict within the institution of marriage or because the sexual contact can take place both within the institutions of marriage and outside the institutions of marriage. Normally, it is expected that sexual contact is made between boys and girls, men and women within the institutions of marriage. But nowadays, because of various factors, because of use of social media and also because of the impact of influence of pornography. I remember few months back I made a presentation that why people some boys and girls they get engaged in sexual activity before marriage and to what extent the pornography has impact. I don't want to talk about that, but according to my view pornography is bad for society. It should not be encouraged, but of course in some cases some doctors they do advise some people with certain sexual disorders to go for pornography. Anyway, let me not talk more about that now. So I go to the next slide. Next slide, please. And now I'm referring to slide 5 of my presentation. Yes, thank you so much. And there now I talk about the introduction and rationale. So I said in the beginning, it's also a question of debate whether alcoholism should be promoted or it should be banned, or there should be certain parameters wherein, and people should be encouraged to consume alcohol within those parameters. Normally, alcohol use is not good for health. People have their own perception. I had a long interaction with various stakeholders, various health professionals. Uh, there are some cultures, and even within India itself, there are some cultures where alcoholism is very bad, but there are some cultures where it is not considered as a bad. It is accepted in the society. So the views of people varies from people, person to person, country to country, society to society. I am sure some of the participants from other countries, maybe Germany, Netherlands, or Caribbean countries, European countries, African countries, Asian countries, they might be having their own experiences of alcohol use in their society and how it is looked at. But uh, so it all depends upon culture to culture. I cannot make a statement at this juncture that alcohol should be totally banned, because it's a part of the hospitality industry, including airline industry. I remember I have traveled to some countries when we have international. I from being from India, whenever I take international travels, so international sector, some airlines they serve alcohol openly, but of course within limits, and also in some nowadays in some parties and some other social gatherings alcohol is served. So I cannot make a statement, but without wasting much time, I must say that now I'm talking in general how alcohol is irrespective of sexual disorder, how alcohol is connected with general well-being or general health profile, physical and mental health, including sexual reproductive health of both sexes. Both sexes means both men and women and boys and girls. So in this context, I say that I make a statement that through this today's conference presentation, that alcohol dependence, alcoholism, refer to I'm talking about alcoholism, alcohol dependence. So those who take alcohol not every day within limits, there are certain parameters of defining the words alcoholism and alcohol dependence. That I will talk little later. But so a person taking alcohol once in a week or once in a month cannot be called an alcoholic, or cannot be called as a person who is dependent on alcohol. But those who are alcoholic, those alcohol dependent, it has a harmful pattern uh, of use of there is a harmful pattern of use of alcohol. So alcohol consumption in general, it has a harmful impact on overall health indicators and other socioeconomic developmental aspects of people, and also it's a pattern of alcohol use that has caused damage to the person's physical and mental health. So physical and mental is also very important. Apart from sexual and reproductive health, sexual disorders, it's also physical and mental health of a person which gets impacted by alcoholism and alcohol dependence. And also that there is a behavior pattern. Sometimes apart from social disorders, people get violent, there is social violence, and that we find media reports coming from various parts of Europe and countries including US, America, in some cities where in pubs there is gun firing, there is gun violence. It has become very common where people get violent and they just use their weapons to kill innocent people. So alcohol dependence is also connected, apart from sexual disorder, connected to overall physical and mental health of people. Also it is connected with sexual reproductive health of people. So, but and also we can use the word unhealthy, apart from the alcohol dependence, alcoholism, you can use the word unhealthy alcohol use. So when you are talking about unhealthy alcohol use, so unhealthy alcohol use includes any alcohol use that puts health or safety at risk or causes other alcohol related problem. So so we need to look at in totality. We need to look in the context of a person's his or her background, her overall health profile, her the upbringing, the social values, the cultural values, the type of society you are living in, and the type of family life education, the type of upbringing he or she has undergone. In case even sometimes if the parents have gone they're subjected to sexual violence or maybe family violence or any type of abuse in the family, that also impact on their children. So these plus social values plus overall person's own physical mental frame of mind, that also impact on all those things. But and also connected with this alcohol consumption is a word which is known as binge drinking. And this is a binge drinking a term. It refers to a pattern of drinking where a male has a 5 or more drinks within 2 hours. Uh, I say it again. According to the definition of binge drinking, a pattern of drinking drinking alcohol is evident, wherein a male has 5 or more drinks within 2 hours, or a female has at least 4 drinks within 2 hours. So binge drinking causes significant health and safety risk. Now next slide, please. Now I refer to slide 6 of my presentation. So in next slide, I will be talking in particular. Yes, in the previous slide, next slide, slide 6. Yeah, right. So in the previous slide, I talked about interconnections between alcohol consumption, alcohol dependence, alcohol use, people who consume alcohol, with overall well-being of the people, their physical and mental health, their and how this their physical and mental, and also including their past experiences, their past experience of violence or abuse, and their overall health parameter. It has impact on overall development of adolescent boys and girls. Yes, in my work, I'm talking more about how the alcohol dependence impacts sexual disorders among adolescent boys and girls. So adolescent boys and girls are those people who are normally it is defined in for those youth who are in the age group of 15 to 19 years, but it can vary from country to country and society to society. So now in this slide 6, I'm talking about how alcoholism and sexual disorders among adolescents in the context of sexual disorders. And also I said previously, these two terms, sexual disorders and sexual dysfunctions, they carry the same meaning. They are used alternatively. So now this slide I'm going to talk more about how exactly the alcohol dependence is connected with sexual disorders. But in this context, before I go ahead, I must tell you that some people are under the wrong impression that consumption of alcohol, after consuming alcohol, people become more romantic and people get more pleasure during sexual contact. But it's not so. In the beginning, people may get more pleasure, but after alcohol consumption, at the end of time, people don't have sexual pleasure. Rather, they have become violent and they become depressed because they don't get sexual pleasure. And there are various forms of sexual disorders which take place in case of alcoholism, alcohol dependence among adolescent boys and girls. So let's talk about that. So alcoholism is linked to more impairments. I'm referring to slide 6 of my presentation. So where I say that alcoholism is linked to more impairments in sexual performance, including so its consequences are reflected mainly in two forms. So in one is erectile difficulty, wherein a person's penis does not become erect or remains hard for a longer time, so that he can have a good, he can insert his penis into the women's or girl's vagina. So the penis does not erect enough for a longer time, for a required, I should not say longer time, a required time, so that he can have a sexual pleasure with her opposite partner, women and girl. And in case of women, there is a vaginal, because of alcoholism, there is a vaginal dryness. And this vaginal dryness, according to my research findings, there are two contributing factors because of this. One is that vaginal dryness is because of alcohol consumption, number one, and also it may be because of other health parameters, especially thyroid problems. It is hormones also. So if there is hormonal imbalance of very thyroid, hyper or hypothyroid. So this may also called. So it depends. It's for the medical doctors to decide what exactly the cause for vaginal dryness. But vaginal dryness can be cause of alcohol dependence also. So now I go to next slide. So now I am referring to slide 7 of my presentation. Yes. So in this slide, I said that so sexual. Now I'm talking specifically in the context of my work. So the slide which right now appearing on the I can see on the screen. This shows how a person feels depressed and people feels depressed and unsatisfied with alcohol. Ultimately, alcohol use does not lead to pleasure so long as so long as sexual contact is concerned. So in the context of sexual contact between men and women, between boys and girls, between adolescent boys and girls, it does not give any pleasure. So sexual disorders are reflected in the form of four major parameters. More specifically, sexual dysfunction is generally or sexual disorder is generally classified into four categories. So there is one category where there is desire disorders. So there is lack of sexual desire or interest in the sex. So after all, in case of alcoholism or alcohol dependence or alcohol abuse, it is applicable to both boys, adolescent boys and girls. There is a lack of sexual desire. So it's a wrong perception through media and through other digital channels, the digital sources that people become more romantic and people get more pleasure. Rather, on the contrary, there is a lack of desire and desire disorders. So there is less of inadequate desire for sex in case of both boys and girls when there is alcohol dependence. Also, there is arousal disorders. Arousal disorder, when I use the word arousal disorder, it refers to inability to become physically aroused or excited during sexual activity. As we know that when actual sexual contact is made between adolescent boys and girls, they need to be adequately aroused. I mean, aroused in the sense that the girls uh, erotic parts like breast nipples need to be becomes hard and her uh, and also her vagina becomes wet and on part of male apart from other physical evidence her, his penis becomes erect and his penis also becomes lubricative and it becomes uh, greasy. So these are these are, but in case of alcohol abuse or alcohol dependence, there is a sexual arousal disorders. So these arousal disorders is evidence in case of both adolescent boys and girls. Also there is orgasm disorders. Orgasm, you know, orgasm is a climax wherein both male and adolescent boys and girls they get maximum satisfaction, and this is a situation wherein man boy discharges his semen from the penis into women's vagina. But he is in case of alcoholism or alcohol dependence, the adolescent boy is unable to get orgasm. So with the result, both boys and girls they remain unsatisfied, and it has impact on other aspects. So they don't get climax, which is supposed to be the end point of sexual pleasure in two sense. And also there is pain disorder. This is also very important. I said in the beginning, this is pain disorder in during intercourse. Pain disorder is evidence in the form of uh, brain disorder is evidenced both by adolescent boy as well as girls, and this is evidence in the form of number two aspects. One is vaginal dryness. There is vaginal dryness. I told you because of alcoholism, there is vaginal dryness, and but other health parameters and other sexual past experiences also may be responsible for vaginal disorders. So it is very important for us to remember that other health parameters, including past bad experiences about sexual abuse or family violence, including if he or she has a she has a rape experience during childhood, so that also has a impact on vaginal dryness, including hormones and thyroid. So apart from alcohol, this also is vaginal dryness is because of these parameters, their overall health profile and their hormones and thyroid problem. And also it is the other reflection of pain disorder is decreased sensitivity of the penis. So penis also, on the case of vaginas, there is vaginal dryness. So people don't enjoy the sex, and also the decreased sensitivity of the penis. So when a person is drunk or alcoholic, the penis does not get adequate sensitivity. It is not becomes erect enough to give sexual satisfaction. So they both remain unsatisfied, and it has many. It has this in turn has impact on many other aspects of the health, which I'm not talking because it is beyond the. I must have a look at my watch. So now I go to the next slide. So this is the source I've given. In this slide, the picture which you can see in front of this computer, where a man in beard is just in half sleep. He's on the table in sleep mode, half sleep mode, and we can see a glass with some alcohol. And again, when I'm talking about alcohol, we have to see that alcohol. There is a wine, there is a beer. The alcohol content differs from product to product. So the amount of alcohol available in whiskey and brandy and rum and alcohol of consumption, and the amount of alcohol, available in beer, it's not same. It differs. So we have to remember that. So now we go ahead. In the next slide, now I say that why my work is important. So here I say that me, as the who is the author of this presentation, I say that alcohol abuse or alcoholism causes a high burden of disease. Yeah, right. Now I tell about objectives. Yeah, I'm so sorry. I forgot to tell them. My, in terms of objectives of my work, the prime objective of my review paper, my paper is a review paper because where I have, it is not, I am not collected primary data from various sources. I am not taken a separate project for that. So I have collected data from various sources and I have analyzed the data according to my wisdom. And according to my research and knowledge, in view of these objectives. So my review paper is to, the objective of my review paper is to present the framework within which alcohol dependence or alcoholism affects sexual disorders among adolescent boys and girls. So this is a prime objective. And also my work outlines alcohol abuse, uh, how alcohol abuse is significantly associated with sexual dysfunction or sexual disorders. As I said in the beginning, that alcohol abuse or alcohol consumption or alcoholism is apart from sexual and reproductive health of boys and girls. It is also impacts overall physical and mental health of individuals. Okay? So this is the objective. Now I talk about and now I should talk. Yes, I'm sorry. Just give me 2 minutes. Yeah, now I'm talking in research methodology. Yes, this is the right slide on my computer. This is the right slide. So in my work, I talked, the previous slide talks about objective, where I have said that I'm going to talk about interconnection between alcohol dependence and sexual disorders, and also how the alcoholism is connected with overall physical and mental health of adolescent boys and girls. So now in terms of research methodology, I have used, there are two types of data, we know, primary data and secondary data. But in my work, I have used the word secondary data. I have not collected any primary data because primary data I need to take a separate research project. And I need to collect data from the field to depict, to see how, to show how alcohol abuse or alcohol dependence affects adolescent boys and girls' sexual and reproductive health, and especially sexual and reproductive health in general, and sexual disorders and sexual dysfunction in particular. So I've used secondary data in my work, and the data which I have used in my work is qualitative in nature, not quantitative. And I have not, and most of my work data are secondary in nature. which I have collected from social like books, book chapters, journal articles, government publications, publications of World Health Organization, International Labour Organization, publications of government publications, publications of university and other research institutions, and all the data sources I have quoted in my work under the reference section. So all the data which is collected from various sources, I will tell the sources which I from where I collected data for this preparing this research abstract at the end of this slide little later, and all the data analyzed in a descriptive manner. So I have not used any statistical or sophisticated or advanced statistical or mathematical techniques to analyze the data. I have used descriptive research method. So from this point of view, my data is my work is a desk-based research in the sense that I collected data from various sources, and I in my individual capacity analyze the data with my own research wisdom. But apart from this that trend obtained from the analysis of data which is collected from various sources, my work also benefited from my personal experiences, my educational background, my qualifications, and also my interaction with the people who have taught me, professors who have taught me, including my interaction with various stakeholders, various health professionals, para and medical and paramedical staff, both located in India as well as in other countries. And in these countries, I must say that I have a special interest for research. My area of expertise is sustainable development, demography, and physical and mental health of women in general, and sexual and reproductive health of women and girls in particular. So in this I have presented, visited several countries to present my research work. So during my travel abroad in countries like USA, UK, Turkey, Philippines, Ireland, Canada, Hong Kong, Greece, I have also traveled to Germany, Netherlands, Poland, Nepal, Belgium, Switzerland in connection with my presentations, in connection with presenting my research work. So whenever I had interaction with these people, stakeholders located in this country, so what experiences they shared with me in the context of alcohol dependence, interconnection between alcohol dependence and sexual disorders among adolescent boys and girls. So my work has also benefited from inputs we have received from stakeholders who are located in this country. So this was very briefly about the methodology I used my work. Now I'm referring to slide 12 of my presentations. Of my PowerPoint slide 12, where I'm talking about data analysis and interpretation, including key findings. So now I will tell how exactly the entire what is the framework within which interconnections between alcohol dependence and sexual disorder takes place. So in this context, it's very important to know that alcohol dependence and alcoholism, and especially heavy drinking, is the situation. Heavy drinking is a contributory factors for sexual disorders among adolescent boys and girls. And heavy drinking is also defined known as binge drinking. And now I tell you how exactly is it defined, is measured. This alcohol consumption is measured in exact measurable terms, where we use the word heavy drinking and binge drinking. So consuming 50 drinks, and each drink comprised of 40 grams of pure alcohol. So as I told you in the beginning, the amount of alcohol in beer is different, amount of alcohol in whiskey or brandy or rum is different. So each drink comprising of 14 grams of pure alcohol. So if there are 15 drinks uh, uh, or more than per week, this is then it is known as heavy drinking or binge drinking. So binge drinking, wherein people, adolescent boys and girls, they consume 15 drinks or more per week, wherein each drink is should be comprised of 14 grams of pure alcohol. So in this type of situation, there is a likelihood that sexual disorder will take place, where there will be painful intercourse, people have less desire in they will have less sexual desire, and they will not become romantic at the time of actual making intercourse or making. It is applicable to both boys and girls. So sexual disorder dysfunctions may be experienced by adolescent boys and girls in the form of premature ejaculation. So all the at the end of the end product is that people, there is a premature ejaculation. Premature ejaculation in the sense that uh, the man ejaculates his semen in her vagina before he adequately arouses people and before he gets adequate sexual pleasure, and also before he in turn makes herself her sexual partner adequately sexually satisfied. And then also there is, I said in the previous slide, the inability to reach organism. I don't want to talk about that again because it's repetition. And also alcohol abuse harms health and relationships within the family. Recently, being apart from a sexual reproductive health, alcohol consumption also implications on other aspects of the overall social development. So in this context, we must remember that health health and relationships are also within the family also impacted by the alcohol consumption, alcoholism, alcohol dependence, and also it damages the social fabric due to resulting violence, crime, drinking, etc. So in case of alcoholism or alcohol dependence, as boys and girls, they are also likely to, apart from sexual disorders, they are also likely to experience violence, crime. Uh, for example, we have a passage of driving. In many societies, adolescent drinks alcohol. Uh, Many people think that drinking alcohol is beginning of the setting, set the mood, good mood, to be in good mood, but it's a wrong perception. That it's not so. So we must remember that alcohol in any form, it is linked with sexual disorder. But I told you that sexual disorder, it may be alcohol consumption may be one of the factors for sexual disorder, but it may not be the only factor. There will be other contributing factors due to which adolescent boys and girls may have sexual disorders of various types. The boy may have the erection problem, or and the girls may have vaginal dryness, and he may have his penis will not remain hard or erect for the required period of time. So there may be many contributing factors. I think I need to speed up. Yes, so this is what I said in the beginning. Because of because of the wrong information, people, now I am referring to slide 13 of my presentation. So because of the information which people get from internet sites, from Google sites, so from internet there is a lot of wrong and unscientific information available. We must know what is bad information, uh, which information available in the internet is scientific or which is wrong information. So people get a wrong information that alcohol sets a mood, but in fact we must remember that alcohol is a depressant. In fact, it is a hindrance for overall physical and mental health and development, and also sexual reproductive health. And also you must remember that drinking more uh, alcohol decreases sexual desire and decreases sexual desire and dampens the mood. It spoils the entire mood on the part of both adolescent boys and girls. And over and above, it's also very important for us to remember that although consumption of even a small amount of alcohol has the potential to contribute to sexual desire, a little in the beginning, a little consumption of alcohol people may think that it is increasing our sexual desire, but it can decrease sexual performance, but it does not happen. But when it comes to actual making sexual performance, when a person where sexual performance is a situation wherein the adolescent boy has to insert his penis into the vagina of the adolescent girl for a adequate time, so that he has adequate sexual contact, and he inserts his vagina, his penis into vagina, and for maybe 5 minutes, 7 minutes, or whatever it may be, and the girls feel satisfied. She also discharge, and man also ejaculates semen in the vagina. It does not happen. So people don't get orgasm or climax. There is a lack of climax. There is a lack of sexual desire. There is a lot of sensitivity on the part of men's penis, and there is a situation wherein female have vaginal dryness. So these are the parameters, and these are the main implications or repercussions of alcohol consumption among adolescent boys and girls, so long as their sexual health is concerned, or sexual disorders or sexual dysfunctions are concerned. So now I conclude. In conclusion, I would like to say that effects of alcoholism among adolescent boys and girls are erectile dysfunction. Erectile dysfunction is a situation wherein the adolescent boy's penis does not remain hard enough and erect to satisfy himself as well to satisfy her partner, I mean the girl or the women. And also dysfunction in satisfying organism, there is neither boy or girl they get orgasm. And also there may be premature ejaculation situation wherein the man ejaculates his penis in a woman's vagina before he or she gets adequately sexually satisfied. But in this context, we must remember that there may be situation where both adolescent boys and girls are they depend on alcohol, and also there may be situation wherein either boy or girl it depends on alcohol, but the impact will be there will be sexual disorders. Either both are alcoholic or they depend on alcohol, or only sexual adolescent boy depends on alcohol, sexual girl does not take alcohol, or sexual or adolescent girl takes alcohol and sexual boy does not alcohol. So whatever the situation, in all three situations there will be sexual disorders, but how exactly its impact will be reflected, it depends. It depends from person to person and depends from situation to situation. It also depends upon age of a person. As I said in the beginning, sexual health or sexual functions is not impacted only by alcohol alone. It's also impacted by other health parameters like hormones, like thyroid, like their food habit, their lifestyle. If they are used to they have exposed early in the past, they have been exposed to violence, or they including yes, drug abuse, drug abuse and smoking. So these are other contributing factors which impact on sexual health of adolescent boys and girls. So we need to look in totality of the whole situation. So apart from alcohol, these are also factors. So there is a premature ejaculation, and also there is a delinquent behavior among adolescent boys and girls and youth. There is a deterioration in family relationship. So this is another implication apart from sexual dysfunction. There is also family relationships are adversely impacted because of this. And also I said in the beginning, people also get violent. There are cases of drink driving, and there are accident takes place. And manifestations among adolescent girls are in the form of in the case of adolescent girls, there is the manifestations are in the form of decreased sexual stimulation, decreased vaginal lubrication, as I said, and because of vaginal lubrication, there may be painful intercourse, difficulty reaching orgasm or climax. So with this is the by and large I want to tell you in my presentation. And in the conclusion, I also say that in case of alcohol dependence among young people, there is a risk of sexual disorder and other alcohol-related problems. There may be other problems which are connected with alcohol, not only sexual disorders. But most important, very important for us to remember that early initiation of alcohol abuse provides indication of added and potential future burden among adolescents. So if they, in case they start, adolescent boys and girls, they start consuming alcohol in the earlier years of life, it means there are more likelihood of them having, they being at the increased risk of both sexual disorders as well as other physical and mental health indicators, and including other sexual and reproductive health problems. So this is the whole framework within which alcohol dependence, and alcoholism, and sexual disorder in general, and in particular, and physical and mental health of people in general is impacted by alcohol. And also in conclusion, I say that potential future burden includes, so the alcohol consumption has an impact right now and also for the future. In terms of future implications, it has increased risk of academic failures. So adolescent boys and girls who are alcoholic or who depend on alcohol, they are also likely to encounter academic failures. They may not perform well in their college university exams, and also it may impact on their physical and mental health disorders, and also there may be antisocial disorders. Thus, adolescent boys and girls need to routinely assess sexual functioning if they are alcoholic, so that other factors contributing to sexual dysfunction can be ruled out. So in case they find that they have any type of symptoms, there may be intervention. They must approach the sexologists or medical people or other health providers in their society, in their country they're living in. And they must get timely help so that their health, sexual health disorders are not further complicated. So we all as stakeholders, we have our own role to play. I as a researcher, I have my own role to play. Parents have their role to play. Physical society, civil society members, including government stakeholders, including universities and colleges, they have a role to play. Maybe colleges, universities, in their curriculum, they can advocate through their curriculum, through formal non-formal education, they can encourage the adolescent boys and girls to stay away from alcohol, and to also to see that they become responsible enough when they think in terms of alcohol consumption on the one hand and how it has impact on the sexual health and sexual pleasure for both boys and girls and overall mental health. So these are the keywords I have used. My word: alcohol dependence, alcohol abuse, alcoholism, heavy drinking, sexual disorder. I am referring to 17 slide of my presentation. Binge drinking, alcohol, adolescent boys and girls, sexual dysfunctions. So these are the keywords I have used. And now in the slide 11 of my presentation, I have quoted the sources which I have used my work. In total, I have referred to 8 sources. So in the slide 18, I have used 4 sources, where I said in the beginning I have taken the use the publications brought out by international organization, World Health Organization, including individual authors. So 17 slide refers to references, and the remaining 4 references I have used in the slide 19 of my work. So in total, I have referred to 8 sources for the purpose of my work: World Health Organization, American Academy of Child and Adolescent Psychiatry, including United Nations Office on Drug and Crime, and many other sources. So thank you for your kind attention. Any questions or any comments or any aspect of my presentation? And I hope within the given time I made a good presentation. And in case I'm now with this I end my presentation, and now I'm open for discussion for any questions coming from anybody. And in case the time available right now, today's conference does not permit, then anybody after the conference can reach me with any questions or any comments on any aspect of my presentation through my 2 ways. One is my WhatsApp number 92243804445. This is connected WhatsApp number. You need to add +91 which is country code, and my email address Dr. skmisrain@yahoo.com. So there is 2 channels I can be reached with any question after this conference. So with this I end my presentation. So I'm open for discussion, and thank you so much for kind attention, and thank you once again the organizer of this conference to give me an opportunity to present my research, which I presented today by webinar mode, where I talked about interconnections between alcohol dependence and sexual dysfunctions among adolescent boys and girls, which I said in the beginning Adolescent boys and girls are those who are in the age group of 15 to 19 years. So with this end my presentation, thank you so much.
Thank you, Dr. Santosh. That was a very, very great presentation.
Thank you so much.
Yes. Does
I,
anyone
I would
have any queries? If
right
anyone
now,
have any queries, please ask Dr. Santosh Kumar. He's available for queries.
yes, I'm available to answer the questions coming from anybody.
I hope
I
there are
don't,
no queries, Dr.
I hope
Santosh.
I don't find any question. Anybody after this conference, one can reach me with at my email address and my through WhatsApp number for any aspect of my presentation or for any queries.
Yes, I'll share your mail ID.
Yes. I request you to share my contact details with everybody, and I
Yes,
would be
I'll
happy
share.
to respond. I would be happy to respond to the questions and queries.
Thank you, Dr.
Thank you so much.
Santosh.
Thank you so much again.
Yes. Okay, let's move on to next presentation by Amulya Prakash, Haywood Regional Medical Center, USA. Title of presentation is Chemotherapy-Induced Peripheral Neuropathy in Multiple Myeloma, Practical Recommendations and Recent Advantages. Dr. Amulya Prakash, are you ready with your presentation? I can't hear you, Dr. Amulya. I can see you, but I can't hear you. Can you please check your sound system? I can't hear you. Okay, can you please exit the meeting and then again join the meeting? Yes, Mr. Amulya Prakash. Can you hear me? I can see you, but I can't hear your voice. Kindly check your sound. Can you please check once again? I can't hear you. I don't know the reason, but I can't hear you. Mr. Amulya Prakash, are you ready to present? Mr. Amulya Prakash, are you there? I'm so sorry, but I can't hear you. Are you using an Apple device or a MacBook? Audio is not working.
Hello.
Hello, Mr. Amulya Prakash. I can hear you.
Okay, all right, let's begin. Do you have my presentation there?
Can you wait a moment?
Sure. Sorry about that.
It's okay.
All right. Okay, can I begin?
Yes, you can begin now.
All right. Hello, everyone. Thanks for joining me today. Sorry about the technical glitch we had. So I'll try to be as quick as possible to finish in time. So today I'm going to talk about chemotherapy-induced peripheral neuropathy in multiple myeloma patients, practical recommendations and recent advances. Next slide, please. So a background into the disease we're talking about, multiple myeloma is a malignant plasma cell disease which accounts for 10% of all hematologic malignancies. According to American Cancer Society, 5-year survival rate cumulative we are talking about here is 58% in United States. Peripheral neuropathy can be a neurologic complication associated with the multiple myeloma itself, the disease, or its treatment. Next slide. So chemotherapy-induced peripheral neuropathy will refer as CIPN is a common adverse reaction associated with various chemotherapeutic agents. Several classes have been identified, including platinum-based agents like oxaliplatin, taxanes such as docetaxel, thalidomide, bortezomib. So CIPN is a progressive, persistent, and often irreversible adverse reaction of many antineoplastic agents. It severely affects quality of life, and chemotherapy response can be impaired because of poor adherence, or sometimes we have to do a dose reduction. Next slide. So the incidence has been reported to be somewhere between 12 to 90%, and the range is really wide because of various degree of symptoms patients experience while they're on this chemo. Clinical features predominantly include sensory neuropathy that may be accompanied by motor or autonomic changes. Uh, symptoms are mainly sensory, but motor symptoms appear all the time, like mainly in the form of distal weakness in upper and lower extremity. Autonomic symptoms can include orthostatic hypertension, constipation, etc. WHO grading for CIPN is from 0 to 4, 0 being no symptom there, and 4 being paralysis. Next slide, please. So the class of drug I'm gonna specifically talk about in context of multiple myeloma. So there are two main agents that have this kind of adverse reaction. The first one is proteasome inhibitor induced CIPN. Bortezomib is the most common proteasome inhibitor agent used in multiple myeloma. So, in short, BIPN is an axonal sensory motor neuropathy characterized by sensory loss, including neuropathic pain and motor weakness in distal upper and lower extremity. In a phase 3 trial, the median incidence of sensory CIPN in patients given bortezomib was 37.8%, with median incidence of severe neuropathy in grade 3 to 4 was 8%. There was a major APEX trial which had a similar finding like the one, I just stated about. Next slide, please. So intravenous bortezomib has a higher rate of incidence with, the severity of symptoms is also higher, 8 to 16%, while on the other hand, the subcutaneous bortezomib is tolerated better with a lower incidence of grade 3 or higher CIPN up to like 6%. So a lot of times we have noticed that with dose reduction, the symptoms um, are less severe and patients are better able to tolerate. However, that obviously impacts the disease outcome. Next slide, please. So regarding pathogenesis, bortezomib is basically reversibly binds to proteasome 26S subunit to inhibit proteasome ubiquitin pathway, leading to cell cycle inhibition and apoptosis. The exact mechanism of peripheral neuropathy in secondary to this medication is not so clear at this point. However, there are theories that it accumulates in the dorsal root ganglion neurons, indirectly causing CNS dysfunction, including glial cell activation, mitochondrial and endothelial network damage and inflammation. Bortezomib can cause, because it causes mitochondrial dysfunction, it triggers aerobic glycolysis within the sensory neurons, which may lead to metabolite efflux, sensitizing primary afferents, sensory afferents, ultimately causing neuropathic pain. Next slide, please. So there are two mechanisms suggested, but ultimately, it leads to axonal degeneration through different apoptotic pathways. It basically involves small myelinated fibers, A delta, unmyelinated C fiber, and large myelinated fiber, which causes normal pain signal transmission. Next slide, please. Clinical features. So BIPN typically occurs within the first treatment cycle with maximum, symptom noted around, like it plateaus around cycle 5. Symptoms are obviously more sensory than motor. Sometimes, rarely, I would say, certain polyradicular neuritis has been reported. In terms of electrophysiology, nerve conduction study predominantly reveal low amplitude of sensory axon potential with predominant small fiber involvement. Next slide. So the next class of agent we have is immunomodulator induced CIPN. So thalidomide is a synthetic glutamate inhibitor. This is the medication that was used for as an antiemetic for pregnancy-induced nausea and vomiting back in 1960s, which was withdrawn because of severe side effects. But this medication is now being used for multiple myeloma treatment. So thalidomide induces neuronal cell degeneration, has direct toxic effect on DRG neurons. It can downregulate TNF alpha and inhibit K beta, causing dysregulation of neurotrophic factor activity, thus leading to neuronal demyelination and accelerated neuronal cell death. Next slide, please. Clinical features. So neurologic complications are usually like higher with prolonged exposure. 70% of the patients treated for 12 months will develop CIPN. In terms of electrophysiology, thalidomide is most frequently reported to cause a length-dependent axonal neuropathy. Again, sensory symptoms are more predominant than motor. There's an increased risk of complication if combined with bortezomib, which happens to be the case most of the time. Next slide, please. So this is a slide here, comparing bortezomib with thalidomide. So as we can see, the incidence of grade 3 to 4 neuropathy is definitely higher, and the symptoms are often irreversible with thalidomide compared to bortezomib, where in 50% of the symptoms, 50% of the times, the patients can have resolution of symptoms to some extent after dose adjustment. Next slide, please. So the question is about treatment and prevention. So the current clinical practice focuses on management of symptoms. Unfortunately, there is no highly recommended method of prevention or treatment reported to date. In practice, clinicians should assess the risk and benefit of agents known to cause CIPN among patients with underlying neuropathy with conditions that predispose to neuropathy, such as diabetes, personal or family history of hereditary peripheral neuropathy. Next slide, please. In terms of pharmacotherapy, duloxetine is the only medication that is strongly recommended by American Society of Clinical Oncology. The recommendation is moderate for symptomatic treatment. Gabapentin and pregabalin is not recommended for prevention. Uh, you know, ASCO doesn't give any guideline in terms of treatment for these two particular agents, but in practice they are used very frequently. So again, this is based on clinicians' personal experience, practice guideline with their practice, hospital, whichever. Um, Pregabalin has an advantage over gabapentin that it has higher bioavailability and faster absorption. So someone not responding to gabapentin can be trialed with pregabalin. Topical amitriptyline and ketamine has been found to be effective in certain pilot study, but obviously needs more evidence. Next slide, please. Again, now we have some more agents here: docosahexaenoic acid, alpha lipoic acid, methylcobalamin, glutathione, dexa dexanibinol. These are all these agents have been found to be effective in small pilot studies. So they're not part of official recommendation yet. Obviously needs more study to study um, to know more about their side effect profile, effectiveness, drug interaction, and all that. So ASCO in general has a moderate against recommendation for all these agents. Next slide, please. Then non-pharmacologic treatment. So these basically usually have low harm profile. So based on clinicians' personal experience, they can recommend exercise. Obviously, is recommended for general wellness, and in terms of treating CIPN, there is a relationship between exercise and the regulation of inflammatory cytokines. So IL-6 is the main cytokine we're talking about here. IL-6 is a pro-inflammatory, which is triggered by exercise, which can have a negative feedback loop on the neurodegeneration triggered by the chemotherapeutic agent we're talking about here. Acupuncture can help with nerve repair by increasing blood flow to the extremities. Nerve block obviously sounds like a very appealing, option. It basically blocks sensation but does not have any impact on nerve regeneration or anything like that. Scrambler therapy. So electrical stimulation therapy can promote axonal regeneration of nerve cells and functional recovery after peripheral nerve injury and also reduces neuropathic pain. Next slide, please. So in conclusion, we know that CIPN is a very emerging diagnosis, with the use of these newer agents, and the symptoms are very debilitating. Often, it, interferes with treatment compliance, requiring reduction, and will definitely impact the outcome. We have some information about pathogenesis and some information about treatment options, but nothing is very solid at this point, which means like we need more research in this field. So these are some of the references I have used in my presentation. Next slide, please. So that would be all about this topic. Thank you everyone for listening. I'll take your questions now.
That was a great presentation, Mr. Amulya Prakash. Does anyone have any queries? If anyone have any queries, Mr. Amulya Prakash is available to answer your queries.
All right. So thanks, Emma, for helping me out, having me here. Thank you, everyone, for
Thank,
listening.
thank you, Mr. Amulya Prakash. So by this, we came to end of our day one webinar. I would like to thank all the attendees and participants of today's conference. Hope you enjoyed it and request you all to attend tomorrow's sessions too. Thank you and have a nice day.